So, good morning, everybody. We keep on updating ourselves in our day-to-day life. Okay, as far as food is concerned, as far as gadgets are concerned, as far as clothes are concerned, in every ways. Why not updating ourselves in the clinical, actual, practical life? And this AMC has brought us the wonderful opportunity and the academic feast in this Sunday beautiful morning under the guidance of great Dr. Nilima Vidyatamre Madam. So I welcome you all on behalf of AMC. I'm Dr. Ashwini Kalyankar. And for this, I like to request Dr. Hemant Dugar sir to come on the digital dais to start the program and do the honor. Sir is practicing gynecologist and obstetrician since 1985. He's having multi-specialty hospital in Andheri East since 1990. He's honorary secretary AMC 2022 and 23, ex-assistant honorary BMC Cooper Hospital. He's associated with Lions Club International since 1992-93 and he's associated with Punavas Special School, Goregaon West since 1994. Welcome, sir. Sir, unmute
Yeah,
yourself.
yeah. Suswagatam, Suswagatam, Suswagatam. Association of Medical Consultants is very pleased to welcome you all on this Sunday morning for a beautiful session on updating ourselves on diagnostics. Today, we have a record number of registrations, total 504. That's the last figure which I got. It is a real indicator of two things: that Association of Medical Consultants under the presidency of Dr. Nilima Vidyatamre is thinking and doing something which gives you a value for your membership. And in today's world of medico-legal problems rising, diagnostics has become an integral part, because at many places, as a defensive practice, the diagnostics are more important than your clinical knowledge. But, and that but is very capital, that today the stalwarts who are going to speak that they're going to enlighten us that it's not so that it's only a defensive practice, but as the science evolves, we have plenty of things to learn from the development which is happening in the field of diagnostics. With these few words, I welcome our President, Dr. Nilima Vidyatamre, to give a welcome address. Dr. Nilima is a practicing gynecologist. She's been secretary of our association consecutively for 2 years. This year she is president. She is the vice president of Kandivali Medical Association, founder member of Mumbai Dhadkan, secretary of Being Doctors, ex-member of Medical Legal Committee Foxy, Best Speaker Award at state level moot court competition. Yes, she is, along with her gynac qualifications, she is a qualified lawyer, gold medalist at DGO exams, and a person who is go-getter and focused, because Association of Medical Consultant is association with mission and commitment. With these words, let us welcome Dr. Nilima Vidyatamre.
Thank you so much, Hemant. And I keep reiterating, that I'm so proud to have you as as the association secretary. The way you start all seminars, inspires me also to talk And once I'm inspired, I don't let it go. I have a wonderful team this year who's supporting me at everything that I am planning to do. And we just had a meeting yesterday. A lot of members were waiting for what is happening for the MPCB, and we were unable to give you any answers because we were not getting appointments. To get appointments with ministers also becomes very difficult when we find that, that we are trying to go against the tide and get something which is not a revenue generating mechanism. So it was a tough job, but we finally managed. We've managed also to approach the center and keep them informed of what is happening through the MPCB itself. That is what we realized yesterday when we went for the meeting with the member secretary of the MPCB, Shri Praveen Darade. Believe me, it was a big eye-opener for both the parties. They really understood our problems. And member secretary himself asked, how do you expect the hospitals and the small nursing homes to establish STPs and ETPs in Mumbai? So we are very sure that we have managed to, enter into that crack and explain to them our problems. And we are hopeful that we should be able to find some way out. Unfortunately, it's a central act and the MPCB really has its hands tied, and we will have to go to the center to get things changed. But currently, for breathing space, we have managed to allow the MPCB to formulate the format of the declaration form, which may help us to tide over a few months till we are able to take further steps. From our side, the homework is nearly completely done. Newer suggestions are coming up. We are taking suggestions from everybody and we are working our way. Dr. Lata Ghanchamnani, Dr. Sunil Singhal, Dr. Leena, Dr. Mrudula, Hemant, me. A lot of hospitals also have contributed by giving their effluents for treatment, analysis, lab analysis. We have interns who are working for us. We have done RTIs. We have conducted surveys. So from our side, nothing has been left undone. We're now working towards the finer points of the MPCB. We've been able to get onto the committee which is working on the MPCB, and every third Saturday they are going to have meetings, and we are going to attend that very, very sincerely and try to find a solution for us. Shutting down may be needed, so be aware, all right, and be ready. All right, we need to show our unity at this time. If we don't show our strength, whatever work we may do will not bear us fruit. We are also contemplating further legal actions, so be with us steadfastly. My appeal to you all again is organ donation is something I've taken very, very, very seriously, and we are working towards the end goals of organ donation. I would really again request all of you to please register as donors and get those cards, take the e-certificates from AMC office, frame them and put them in your consulting rooms. Your patients will start asking you questions. And unless we have awareness amongst patients, we will not get the donors. So kindly, please cooperate with us. We are doing it very, very sincerely. Nearly 9,000 trees have been planted in the names of AMC members on their birthdays. I hope you're getting the tree certificates and that you have managed to frame and display them in your clinics to inspire your patients also to do that. We're doing a lot for the environment, and MPCB also happens to be doing a lot for the environment. We have woken up late. Yes, they have also woken up late, but we have woken. So I think it's time to do our bit for the environment. My sincere thanks to today's seminar holder, that is Suburban Diagnostics. I hope Dr. Anupa is ready with the schemes that they are going to roll out for exclusively for AMC members, because we believe health of the doctors is very, very important. And without basic investigations, we will not come to know where we lie, where our health is concerned. And that is why Suburban has very graciously agreed to give us a very good discount on the blood investigation. So Anupa will be telling you about it, and we shall be circulating that message also. One more very close to my heart is the AMC clinics that we were supposed to launch. Suburban has agreed to partner with us in that, and they are willing to do at absolutely subsidized rates, or if possible, some investigations even free of charge for the poor patients. So any hospital wanting to host the AMC clinics, Suburban will be very, very happy to cooperate with you and be your partners and help you in the diagnostics part of it. I want more and more members to come forward. We want to establish ourselves as Rotary, and the Lions Club have established themselves as charity doers. So they are using doctors for the charity. So why not AMC? The own members, who are doctors, are doing free of charge work over there, do it in their own hospitals or in certain premises where a charity can be done and where these camps can be held. So I would want you all to come forward and volunteer to carry on these AMC clinics wherever possible and whenever possible. I think I am at the end of my speech. Reena is going to tell you and update you about all the lovely programs that we still have on our list. In fact, my people who are very, very close to me are cribbing, Nilima, ek bhi Sunday nahi chhod rahi humko hamari family ke liye. All right. But we cater to all the needs of all the members. So some people are interested in medical legal, some people are interested in diagnostics, some people are interested in cancer, some people. So we are having everything for everybody. So welcome to this webinar, and I hand over to Ashwini back. Thank you very much.
Thank you so much, madam, for such a wonderful words and absolutely amazing work that is to under AMC banner and always inspiring us. I must say you are a true medical influencer for all of us. Thank you so much.
Thank you.
Thank you. I welcome Dr. Reena Mande, madam, to come on the digital dais to update today's program and further programs. Dr. Reena Mande, madam, is a professor and head of the department OBGY at HBT Medical College and Dr. R.N. Cooper Hospital, Mumbai. She's program committee chairman, AMC. She's member of FOXY and COVID Guidance and Vaccination 2020-21. She's president Mumbai Breastfeeding Promotion Committee 2019 to 92, core committee Foxy Violence Against Women Cell 2015 to 21, chairperson Foxy Perinatology Committee 2015 to 17, ICOG Governing Council member 2021 and 22, and many more. My God, such a wonderful CV. Welcome, madam.
It's my privilege to be here as part of the team AMC, and our dynamic president, secretary, and the OB team. We have been working on looking at not just the medico-legal aspect, but we're looking at the financial, the mental and physical health of our AMC members. So I'm glad to let you know that our various programs, of course, I'm going to give you the update of the upcoming programs, but our programs so far have focused on a holistic approach. And today's program works with the adage, physician, heal thyself. So let's look at how we can make our own health better and the health of the people around us. Well, friends, in today's program, we are going to be talking about diagnostics, but next Sunday, that's the 18th, we are having a program focused on cancer and looking at not just the regular stuff, we are talking about various other therapies, home care, palliation, and so on. Followed by that, on the 25th of December, yes, it's Christmas, we are visiting Santa Claus, and hopefully Santa Claus will bring a sack of money into your house, because we are talking about FinCon 2. Financial management and financial health of you all is very important, and we as doctors tend to forget that handling money properly will make the money grow. And we've got a wonderful team from Finovate who also give us technical support for our webinars, is going to tell us, and we are focusing on, this is FinCon 2, FinCon 1 was on Gandhi Jayanti, and FinCon 2 is coming up on 25th December. Please keep your time free in the morning for the session. I'm sure it's going to help you to grow your personal health and widen your practice. January is a busy month for everyone, but in January, we have some wonderful programs lined up, including something non-academic by Ashwin Gidwani, which is a silent comedy, which will be coming up. But on the 26th, we have a fantastic program planned, and we have a bikeathon, which is also going to be coming up with our own president leading the team. And I think Ashwini is also one of those who's very much into this entire thing. And I think Ashwini, you too will be there on your bike with Nilima, and it will be great. So we have a lot of programs, but friends, don't forget, we have a FinCon, which is also going to be part 3 later on in the next year. Plus, we are going to have a DigiCon with digital issues being covered in the first week of February. And our signature event, the AMCon, is on 25th and 26th of February, during which we are focusing on various aspects and certain things about how doctors do things differently. So the first day is going to be focused on holistic health and other aspects. And on the second day, we are going to have people who are doing things differently, not just medicine. And of course, this culminates on 8th March with Women's Day, during which we are going to have the rally. So there are lots of things coming up. Tighten your seatbelts and be ready for a very exciting roller coaster ride and keep your Sundays free for our AMC programs, which promise you not just education, but also MMC points. Thank you all for being here, and please be with us till the end of the program today. Thank you very much.
Thank you so much, madam.
Reena, just 1 or 2 points I would like to add to this. We have already started the medical legal series. Our next lecture will be coming up on 8th of January. Fasten your seatbelts for that also, because we are dealing with nursing home registrations, the MPCB and the fire. So that will be a very, very important topic. And hopefully by then we should have had some kind of a solution and some kind of a breakthrough, So it will be an interesting topic. Thank you.
Yes, and Nilima is an epitome of the saying that the woods are lovely, dark and deep, but I have promises to keep. Miles to go before I sleep, miles to go before I sleep. And I just wonder at her energy. And this medical legal series, Vidya Shetty is, and there is the whole team working on it. My apologies, I forgot to mention that. And I'm sure it's going to be extremely helpful for all of you.
Thank you.
Yeah, thank you so much, madam. Oh my God, such a wonderful and absolutely amazing year ahead. I guess is a complete package of academic and extracurricular activities. So be ready, all of you, and keep your bikes also ready, as madam said. So let's welcome our next, first speaker of the day, Dr. Anupa Dixit, madam, and she will be speaking on newer and updated investigations. Madam is MBBS MD. She is an alum of JNM Medical College, Raipur, Chhattisgarh. She has a work experience of 17 years. Current designation is Laboratory Director or at Suburban Diagnostic. Added attributes are like MMC, accredited speaker, NABL assessor. She is a professional. She has having professional experience of 2 decades of experience in quality management in laboratories, general laboratory medicine with special focus on autoimmunity, special chemistry, and feto-maternal medicine and immunoassays. Over to you, madam, and welcome.
Thank you so much, Dr. Ashwini. So first of all, I would like to thank Association of Medical Consultants, Dr. Heman Dugar and Dr. Reena Vani. I would really like to compliment Dr. Nilima Bhamre for maintaining that level of energy. I have known her since a very long time, but trust me, every time I see her, meet her, the energy is the same. And she's the epitome of social care. I mean, I've seen her take care of her patients so well, and also the medical fraternity now. So compliments to you, Dr. Nilima. Please keep up the good work. We all are there with you in this.
Thank you so much. Thank you.
All right. So today I'm going to talk about, is my screen visible?
We can see the beautiful face.
Okay, not yet.
But not
all
yet
right.
screen sharing.
So just a second. Okay, is it visible now?
Yes.
Perfect. Just give me a minute. I'll just open it.
Just make it full screen if possible.
I'm doing that. I'm doing that. One second. Okay. All right. So the topic for today that I'm going to talk about is not about the outdated per se, but those tests which are near being outdated or are relatively old, but we have newer alternatives to the ones which are currently existing. So as we all know that the times have changed now. Earlier we used to have telephones and now we are working on mobile. Same is true for anything which is old, and there has to be a transition to a new version. Something new has to happen, which is the same happening in the diagnostic industry as well. A little brief on also what I have done is I have basically compiled a few investigations which start from the routine ones to little complex ones as we gradually move. So a few are which are to be replaced and few may or may not have an indication to be still prescribed. But I leave it on to all of you, all clinicians, to decide on that. But from the diagnostic perspective, I'll start with a very basic. I think it's a very, very important test we all look into and look at is the urine routine examination. So we all know about a manual urine routine examination. We all know the conventional method. It's a commonly required test. And it's an older methodology where it comes to the conventional form of urine routine. What the lab does it centrifuges the sediment, we see the urine, we give the values, and there is a lot of variation between the person to person, lab to lab. There is a lot of loss of cell. So the talk is now we should always look at automated urine routine. So make it a point that whenever you have a chance, whenever you have option, ask for an automated urine routine. Why? Because now international guidelines for urine analysis recommend that the study of the urine particle using counting chamber or an automated system is highly recommended, which means that you do not centrifuge the sample, you do not decant the sample, which means you retain the entire cell, you run it like a CBC sample, which is a complete blood count. Similarly, we run the urine sample. So actually the instruments count around 60 to 70,000 cells before it gives you the value of automated urine. So it is highly accurate, it's repeatable, automated, there is less chance of error. Of course, it's standardized. There are controls which are run in the morning. Minimal cell loss, you get the actual urine report. But advantage for the nephrologist being you get to know the source of RBCs in the urine, which is the hematuria, the cause of hematuria. If you say dysmorphic, you know that the etiology or the cause is from the glomeruli. So that's a very, very big tool where we can actually create differentiation. Right at the source, when we have the hematuria sample, you know it has come from glomeruli or non-glomeruli causes. That's one to begin with. Second, I think we all are familiar with this, but it's important to reiterate how CKMB has now been a test which is not really looked at. Now, this is a very old test, started in 1970s, non-specific. Heart, skeleton, muscle injuries may also give a rise to CKMB. It was the most asked test earlier. And it's also one thing we need to keep in mind, it's relatively larger in size, so there is a delay in appearance of CKMB. But now we all know we need to ask for HS-trop-I and trop-T. And I'm emphasizing here, please do not ask for troponin T or I alone. Look for HS. HS means highly sensitive troponin T or HS-trop-I test. Why? Now we all know troponin T and troponin I are the components which we read in our MBBS days, are the protein complex which helps in the contraction of the heart. It is very, very specific to cardiac injury. So when it comes to ST, elevated myocardial infarction, it's become very, very specific. Good point is troponins rise very early and they tend to get prolonged for a longer time. So you actually do not miss out on MI cases. So troponin I, HS-trop-I elevates at 2 hours. HS-trop-T takes around 4 hours to elevate. Post-injury, HS-trop-I lasts for around a week time, whereas 2 weeks is taken by HS-trop-T to last. So at least you have a good period where you can pick up the MI cases. Sensitivity, we all know what is sensitivity is about the true positivity, which means a test which is highly sensitive will about false negative so that you will not miss out on any cardiac case, which is why for troponins, for cardiac MI, we need to have a test which is highly, highly sensitive. So 98% sensitivity is what we are looking at. Specificity, when we talk about, specificity always talks about true negativity, which means it avoids false positive. Again, you still are okay with little false positive, but you really, really do not want you want a true negative picture as well. So specificity 95%, and for troponin I and troponin T has a specificity of 75%. So the point I'm trying to bring here is with sensitivity, specificity be demanding. Ask for the lab, ask the lab for the sensitivity, specificity of every parameter. It will definitely help you in take a proper clinical decision. Again, there are criteria now. One value may not be good enough. There is a rule in, rule out criteria when you do HS trop I trop T. You have a repeat testing criteria, which means you can repeat after every 2 hours and see whether there is a delta variation happening from 6 to 10, which every lab will have a different variable. But thumb rule is repeat the test. If you see there is a delta variation, you can rule in the patient for MI or rule out the patient for having MI. So it's a very, very interesting tool. Again, myoglobulin, I will not repeat this again, but myoglobulin, CKMB are in the same league. It is non-specific, skeletal muscle injury, increases in renal disease, no much spoken about. It has been again replaced by HS trop I trop T. Ask for HS, do not ask for troponin I, troponin T alone. Vidal test, every clinician prescribes it, but it's outdated test. Sensitivity is very low, 63. Specificity again very low. There are a lot of cases of false positive and false negative. Please keep in mind it's detected only in the second week of fever. It cannot be picked up in the first week. So it doesn't stand meaning from the first day of fever when we ask for a Vidal test. Yes, there is an alternative, which is rapid typhoid test. But keep in mind, it's positive only after 5 days onwards. It's not going to come positive even if the patient has typhoid within 5 days of fever. And also, second thing important is that Salmonella typhi is the only one which it can pick up. It will not pick up paratyphi. Gold standard. It has to be blood culture. There is no substitute for having a typhoid test when you don't ask for blood culture. Sensitivity. Now, again, you ask for blood culture. It's very important to keep in mind one set means one bottle. We all know there is a defined designated bottle for blood culture. If you take only one bottle, the sensitivity is around 70%, which is again meaning that 30% cases you are missing out on typhoid. So go for 2 pair blood culture, which means your sensitivity goes up to 90%. Only 10% cases you will miss out, but 90% you are definitely going to pick up. The more blood, the merrier it is. So 99% if you take 3 bottles. So that is the concept on which the blood culture is made. Again, good part, it will pick up bacteria, it will pick up fungi, and it has less contamination rate provided the collection has been done properly. So very, very important, blood culture collection has to be done properly. If possible, ask for the lab technicians to come and do the collection because they're well trained in cleaning it in a way that we don't have any contamination. Now, a frequently asked question is, can we still do a blood culture test if the patient has taken antibiotic? The answer is yes. Why? Because the bottle that we use for blood culture has resin. Now, this resin ball or multiple balls which are there have a capability to absorb the antibiotic, which means that any antibiotic which has been taken will nullify the effect. So please do not hesitate in getting a blood culture done even if the patient has taken antibiotic. But also the way we pick up is due to the change in the color of the bottom, but this is very inherent with the lab. Anyways, that's the gold standard which we need to keep in mind. Montu test. Again, TB is a very difficult case to diagnose. I think that is, all of us have faced this problem day in, day out. We don't know what sample to take, what test to take, but there is a whole lot complexity with the TB. TB testing has to be done on a representative sample. If we don't know the site, there is no test which will pick up tuberculosis. I think that concept needs to be very clear in our mind. Montu test is a very handy test for us. But again, it's an intradermal injection and we have subsequent follow-up where the patient goes back and shows the area of induration in the arm, takes around 48 to 72 hours. But keep in mind, if the patient has taken prior HCG vaccine, BCG vaccine, it will come false positive. What do we do? TB Gold test, although I'm not a very big fan of this test, but again, as said, we don't have any test which will confirm the TB without a specific site or a symptom, which means that IGRA, interferon gamma release assay test is still recommended when it comes to measuring the response to TB specific peptide antigen in body. Sensitivity is 92%, specificity 98%. There is no effect on prior BCG vaccination. Result is obtained within 24 hours. But keep in mind, for TB diagnosis, gold standard is still TB culture. And again, it has to be from the representative sample, which means it will be either the lymph node aspirate, it could be sputum, it could be fluid, but please get a TB culture request done for any TB where you are able to pick up the site and the sample. Otherwise, non-specific, it can be TB gold, but MON2 definitely has to be a test where we need to think about it. AFP microscopy, again, it's an older method. The threshold for detection is very high. So keep in mind, for having an AFP positive report in a sample which is sputum or fluid, you need at least 5,000 to 10,000 bacilli per ml, which is a huge number. So in possibly, there is a possibility you may not be able to pick up the AFP as a representative sample. So sensitivity as claimed by the guidelines is only 38%. So there is a possibility 70% or 80% cases you are missing out on TB by merely doing AFB microscopy. Although specificity is good, which means false positive, it's not picking up false positive. It's giving a true picture of 97% as false negative. But what do we do now? I think there is a test which we all need to keep in mind is about Gene Expert. Now, Gene Expert also has 2-3 variations which have come up. One is Gene Expert Conventional, Gene Expert Ultra. I'm talking about the one which is the upgraded one, Gene Expert Ultra. Again, this is a diagnostic test on TB. This is a PCR-based test. Now with COVID has taught us what PCR means. Polymerase chain reaction, which means we go to the molecular level. The entire diagnostic industry now from conventional serology test is moving to molecular testing. And this is what one small snippet is about the Gene Expert test. It's highly specific and highly sensitive. Whenever we talk about a test which is PCR based, please keep one thing in mind, the sensitivity is very, very good. Even a small portion of DNA which is present in the sample will be picked up by any PCR. WHO recommends Gene Expert Ultra as the first line of test. That's the best part about this. Threshold of detection when it comes to Gene Expert Ultra is 11.8 CFU per ml. Look at the difference. When we have 5,000 to 10,000 bacilli picked up by AFB, Gene Expert Ultra is only picking up 11-12 bacilli per ml. That is the sensitivity we are talking about. The earlier Gene Expert, which is pure Gene Expert, will have a sensitivity threshold of 131 CFU per ml. So as the time is passing, there is a gradual improvement in the technology. Now we have Ultra, which is 11.8 only, which is like 12 bacilli per ml, is a very good number to be picked up, highly sensitive. Also, the threshold, it also, apart from detecting tuberculosis, will also tell you about the rifampicin resistance, with a lot of emphasis on NTEP, which means National Tuberculosis Eradication Program. It has become mandatory now that the molecular genotypic has to be done for every sample, which means your sensitivity to isoniazid, ethambutol, fluoroquinolone, amikacin, kanamycin, captiomycin, all that has to be also picked up along with the detection as well. But that happens in the kit, which the test which is known as XDR, Gene Expert is XDR test. But in Gene Expert Ultra, we do the rifampicin resistance associated mutations. Now, also be aware for every condition now, there is always a mutation test which is present, which gives a clear indication whether the drug is going to work or not. This is where the entire diagnostic industry is heading towards. Again, as we reiterated, TB culture is still the gold standard, indicated in smear negative and drug resistant TB. So it's very, very important to get a TB culture done. Along with any test that you're looking at for diagnostic of TB, please ask for TB culture. Amylase test for pancreatitis. Normally, whenever there is a lower abdominal pain in a patient, we ask for amylase and lipase test together. And we also think amylase is the only test which we should be doing, but be aware, amylase starts rising within 6 to 12 hours of onset, and it will be missed out in patients who present more than 24 hours after onset. So it has a very short half-life. Sensitivity is low. What do we do in such cases? If you have missed that golden period, please ask for a lipase test along with it. What we get is only amylase as a request, but keep in mind that lipase is again very, very important because it rises within 4 to 8 hours of onset of abdominal pain, but it lasts longer. So if you have a short window period where the patient has the presentation and you did a amylase which come all right, it came with a normal, think of lipase as a backup plan because the sensitivity is high, it lasts longer, and you will not miss out a diagnosis of pancreatitis. This we all know. I think less I talk is better, but I really, really want to talk about it because we're still getting requests about beta HCG. We want to do a CART test, a qualitative test. Again, remember that we should ask for a beta HCG serum. That's the diagnostic test. And it is very, very exclusively sensitive. The detection can go as low as 1 international unit per liter, as compared to a high, very low sensitivity of CART test, which goes around 25 times more. So you need 25 times the more volume of HCG before it can pick it up. Serum beta HCG can be picked up 10 days after the conception. So it is rising very high. It's the most standardized test. Ask for a beta HCG serum rather than doing it from a urine test. Bleeding time, clotting time. I think it's high time we stop doing this test because it's poorly reproducible, insensitive. Bleeding time, we'll talk about the time the platelet requires to come and adhere to the injury, and also the vasoconstriction and other mechanisms which lead to the bleeding to stop. But clotting time is where the clotting factor gets activated. And also there are guidelines which talk about the bleeding time fails as a screening test and therefore is not indicated as a routine preoperative test. PT-INR. Ask for PT-INR. Very basic prothrombin time with international ionized national ratio, and then the time taken to clot is what we look at, and it's superior, more quantifiable. You can have a follow-up, it is very much reproducible, there is a number to it. Indication is whenever there is a liver injury, liver condition, or there is anticoagulant which the patient is on, warfarin, please get a monitoring done of INR, and this is what the indication is now. In place of BTCT, please go for PT-INR to get a first level indication on the coagulation status for the patient, especially preoperatively. ESR, it's a very indirect measure of inflammation. It is non-specific, slower, low riser, falls gradually, does not corroborate with the clinical condition of the patient. And keep in mind, please, it again is influenced by the physiological and pathological factors like hemoglobin, RBC, the age of the patient, the gender of the patient, the protein, like in pregnant females, it will be very high. Whereas ESR is the mechanism where we want to know about the inflammation and infection happening in the body. Also keep in mind, it's highly temperature dependent, which means lab to lab, it will vary and it's not going to give us a clear indication. Replace it with CRP, C-reactive protein. This is a very good test when it comes to the corroboration of the inflammation and the infection. It is a more specific marker. It is also used as a prognostic marker, which means you can actually follow up on the inflammation and see if the number is, it's a quantifiable number. If the number is decreasing from 200 to 100 to 50, you know that the patient condition is improving because it rises rapidly and falls also coinciding with the disease condition. It is not influenced by any pathological factors or physiological factor as well. It is fully automated, it's not affected by temperature, and it's the test of recommendation when it comes to inflammation and infection if you want to pick up that condition. Get a CRP done instead. ELICell is a test which is supposed to be done, which was supposed to be done, I should say now, to pick up lupus erythematosus cases. But again, immunology test goes without saying is the first line of choice when you want to talk about autoimmune conditions. Now it is more definitive. ANA, anti-nuclear antibody test by indirect immunofluorescence assay is the recommendation, which means it's more definitive, it is less subjective. ANA test will actually pick up 95% of the cases with SLE positivity. It is a very good screening test, and this is the pattern and the grade at which we get the immunofluorescence. We can actually proceed with the presumptive diagnosis. If any one of you have given this ANA test, you'll get to see there is a table which is provided along with the report, which tells about the pattern which has been picked up for the patient and what does it match with, clinical condition, what antigen it incorporates. So once you know ANA is positive, you can actually go with a specific confirmatory test with monospecific antibodies to pick up a particular condition. It's it's a very good potent screening test when it comes to diagnosing an autoimmune condition. That's the first line of investigation which need to be asked. Even if it is SLE, rheumatoid arthritis also will be picked up, myositis, scleroderma. There are n number of autoimmune conditions where this becomes a very, very interesting tool and important tool for all of us. Growth hormone. Pediatricians here will face this, and there are a lot of kids who come for growth hormone tests for short stature, and this is the normally recommended test. But keep in mind, beyond the first few months of life, growth hormone is secreted in a pulsatile fashion. Now, that is the problem with this test. It's a very good hormone because it's a direct hormone that you want to pick up, but that's a pulsatile secretion. If you do it at one juncture, it may come normal. Other time you do it, it might come high. So you don't actually get the clinical feature and picture out of it. So measuring a single sample may not be of any use. Stimulation test is still recommended. So there is a test which we should know of, should be aware of, insulin-like growth factor 1. Now this is the test which actually is recommended in place of, or maybe growth hormone directly, because it's a peptide released from the liver. It is the test which is to be done to diagnose growth hormone deficiency, pituitary functions, short stature, reduced muscle mass. These are the indications by which you will be able to do this test. It mirrors the growth hormone level. Beauty is this is stable throughout the day, which means even if you do it at any juncture, you will not see that variation. So you do single test, you get a clear picture of how the things are. Sensitivity is 70%. Again, 30% cases you will miss out on, but 70% you are still able to pick up. Specificity is 90%, which means it is negative in 90%. You can be rest assured that it is not the one which is affecting the stature. So it gives a very good clinical indication. Look for IGF-1. Again, a lot of emphasis on reticulocyte count when it comes to anemia diagnosis. Now, anemia is a very, very important condition. You need to do CBC, you need to do reticulocyte count, and there is a manual method which is available. But again, coming to the manual method, there is a lot of variability depending on the staining, the dilution, incubation, and all. Depending which lab you have done, always ask for automated reticulocyte. Ask for it. The reason being, automated reticulocyte count will not only tell you about the automation, but it will give you other parameters like CRC, RI. What is CRC? That is corrected reticulocyte count. It will give you the corrected one. It will also give you the reticulocyte index, which talks about the marrow function. So it's not about the blood. It will also tell you the feature what is available in the marrow, the reticulocyte immaturity index. Very interestingly, it is IRF. That is reticulocyte fraction. Now this talks about the RNA content of reticulocyte, and it's a very good indicator for response of reticulocyte, which means you get to see the improvement in the reticulocyte count. You know that the patient is in the convalescence and is improving. There is less variability and turnaround time is fast. So it's not only about single reticulocyte count, it's about additional information in the form of 6-7 parameters that we'll be getting to know the anemia condition and also whether the patient is improving or not. So this is how it is. This is certainly very, very important. Now, in cases of monsoon and we want to pick up a case of infection, we normally do serology test. As a thumb rule, serology test, when we look at antibody test specifically, as a thumb rule comes positive only post 5 days of illness. So any test, you have to wait for 5 days, get an antibody test done. But keep in mind, antibody test, all the antibody tests have a lot of cross reactivity. So it's very important to be very sure about the diagnosis. Also, what I spoke earlier is about the diagnostic industry is moving from serology to molecular testing. So instead of doing one condition, one test at one time, and then waiting for if the result comes negative, then you go with the other condition, and then again molecular tests for the second one, again result comes negative, you are losing out on time and you are losing out on the timely diagnosis as well. It takes days. Serology test is low specific. You really don't know whether you have picked up the right case or not. It's very, very important to know what test we need to ask. Now, the world is moving towards multiplex molecular testing. Now, what is multiplex? PCR test, which I introduced, is about the polymerase chain reaction. It also means that we go to the molecular level, we find out the DNA of the culprit, which is bacteria, viral in this case, and we pick up and give you the report. But that is one sample, one testing. But now it is multiplexing, which means multiple antigens, multiple DNA of different virus, bacteria put together in one test. You do one sample collection, you do one test, and you pick up n number of conditions or infections. Now, this is known as multiplexing PCR. Now, when we talk about the syndromic testing, it means that you pick up a condition which has alike clinical symptom and sign. All the fevers have the similar condition, which includes dengue, chikungunya, leptospirosis, even typhoid will mimic the same, malaria as well. So these kind of similar like symptom and sign tests are known as syndromic testing, which means they bundle all these similar alike conditions in one. You do a multiplex test, you take one sample and you are able to pick up a lot of conditions. Now, this is where BioFire film array is a very, very important test. It's a novel approach to rapid diagnosis. It's a superly fast test. It takes an hour's time, and you are able to do a molecular testing, molecular detection of microorganisms that have overlapping sign and symptom. That's what we are coming to as syndromic testing. One test, multiple target. For example, one respiratory panel, BioFire, has 22 respiratory pathogens which can be picked up in 45 minutes. What else do we need? If we do a single test in PCR, it will take a lot of time to do 24 pathogen, and it's very heavy on cost as well. It's very fast, it's accurate, easy, comprehensive, and best part is it's a US FDA approved, which means it's a closed system approved by all the nationalities and the international bodies. Highly recommended. Shortens the time of optimal therapy, reduces the hospital stay, and this is the way now the diagnostic industry is moving, not only in infections, but many other conditions where multiplexing has come into the picture. Whenever you hear this word, keep in mind it's about a union, a complex PCR test, which includes multiple organism or antigens in one test. One sample and multiple you are able to pick up in PCR. Dengue, I think this is a very frequently asked question. Rapid dengue cart test definitely is a big no because it's rapid although, but low specificity and sensitivity. And false positive also can come due to other infection, and you really don't know whether you have picked up dengue or some other condition. So dengue ELISA is the one which is recommended. Sensitivity 93%, specificity 99%. For NS1, IgM is still 96 and 99%. IgG is 97 to 100%. It varies. But the point here is always ask for ELISA automation as compared to any of the card tests. Chikungunya also, sensitivity is, IgM can only pick up for 5 days, but beyond that, it has to be a PCR test. Now, every serology test has been moved and shifted to PCR test, and sensitivity is it's highly sensitive, which means you need only 19 copies available with you to pick up, and it's 100% specific. Again, the multiplexing has taken in the form of dengue, malaria, lepto, typhoid, chikungunya tested in one multiplex PCR. So this is where the world is going towards. Now, again, commonly asked is vitamin B12. Vitamin B12 total has active and inactive component. Please keep that in mind. Active component is the one where transcobalamin comes into the picture. Now, with transcobalamin into the picture, this is the one which you actually want to pick up because that's the one holo transcobalamin, the active form is, which will help in the cobalamin uptake, and also it targets the specific receptor adequately. But now there is a test which talks about the holo transcobalamin directly, which means the active form of vitamin B12. It is the bioavailable component of B12. It is the early marker. It can be picked up early. And it seems to be like it's going to replace vitamin B12 as a first-line laboratory parameter to screen for vitamin B12 deficiency. Because then you are not picking up the inactive cobalamin. It's the pure active cobalamin that you're picking up, and you get to know whether this patient actually requires further treatment or not. Creatinine, we all do this test. It's effective for muscle mass, exercise, inflammation, diet. It's a byproduct of all the proteins. It's passed in the urine. And we all know about how creatinine is. But again, cystatin C goes without saying, because it's an excellent alternative to creatinine and creatinine clearance test. It has to be done. It should be done in a kidney condition. It assesses the eGFR value. It is not affected by muscle mass, which creatinine is. A thin-built person will have a low creatinine, whereas cystatin C is not affected by muscle mass, diet, inflammation, and any other condition. Early detection, it's an early detection tool. Wherever there is a kidney disease, this will go high early as compared to creatinine. And returns to normal very quickly. So it corroborates again very well with the clinical condition. So we have to start thinking about cystatin C as well. I'm not saying creatinine is redundant, of course not. But cystatin seems to have an edge when it comes to early detection and suspected kidney conditions, which are little early and also corroborates very well with the clinical condition. Now, there is a big shift which has happened in the semen analysis. Now, what has happened is there is a recent guideline which has come up from WHO on 6th edition on semen analysis. Again, we all know semen analysis routinely is done for male infertility diagnosis, but there is a change and a shift which has happened now in the form of having a computer-assisted semen analysis, which is CASA. This word one has to be familiar with, because it also corroborates about the accuracy, the repeatability, and the automatic assessment of semen. I think this is where we as Pavan is very keen in shifting also now, because it's quite standardized. You get not only the routine semen analysis parameter basis WHO 6th edition guidelines, but it also talks about the motility, concentration, morphology, DNA fragmentation, vitality, acrosome reaction, leukocyte, and lot of other things in a very well automated system, which is AI based. Now, world again, diagnostic is now not anymore manual. It's all moving from automation integrated to AI now. So just to update all of you, in WHO 6th edition, there are few changes when it comes to addition of a parameter like odor, rapid progressive, slow progressive, non-progressive, immotile, total motility has become a criteria now. Residual cytology becomes one more morphological additional point. Sperm aggregate and sperm agglutination has also been added as two parameters which a lab has to report now. There is the addition of round cell in place of pus cells or other cells, because we really don't know whether it is pus cell or not. So little updates which have happened in WHO 6th edition. If you are asking for a semen analysis, keep in mind that you ask for the latest one. Anyways, the ask should be now CASA, computer-assisted semen analysis. It's very informative. Now, this is a sensitive topic. We keep on getting this request when it comes to prenatal diagnosis. Yes, the world is moving from maternal marker to NIPT now. So I think lots are going on in that direction. We all are aware of this. But I'll try to talk about a small segment, which is prenatal diagnosis of fetal anomaly. That's a very common complaint and query we get from gynacs asking about what do we do. So conventional method is you do a whole genome sequencing. You get a cytogenetic test done, which is a low resolution one, and you actually do not know whether we are able to pick up the diagnosis of fetal anomaly during pregnancy. Now, one fact we should be aware of is 20% of stillborn babies have a major malformation, which normally goes undetected. 3% of live births have congenital abnormality. So there is a huge predilection of and chance that a fetus might have, apart from Down syndrome, Edward and Patau syndrome, will also have some abnormality in the chromosomes, which need to be kept in mind. So what is new? What do we do in such cases? Chromosomal microarray analysis, CMA, has made a big shift here, which includes, we should know, first of all, chromosomal microarray. What are we talking about? We are talking about a cytogenetic test. Now, this is very simple. This is a cytogenetic test. Microarray is a technology which is not PCR, but similar to PCR, where there is hybridization happening along with the SNPs, which is single nucleotide polymorphism. This is a little complex, but this is how it is done as a principle. So each microarray contains around 3 million markers for copy of number. So here, keep in mind, we are all talking about the mutation. We are talking about gene. We go to the gene level from the sample that we take from the mother and go and try to target the gene of the fetus. Targeting a huge number of gene, SNP is a single nucleotide polymorphism, as in like a abnormality which can be picked up. So the sensitivity goes up to 15 to 20%, which is a very good number. Now, with American College of Medical Genetics, it also recommends that please do not ask for karyotyping anymore. If you want to do a prenatal diagnosis of fetal anomaly, talk about chromosomal microarray. And this should be the first line of test one should ask for. So what is the indication of doing a chromosomal microarray analysis? Whenever the maternal age is high, there is a family history of abnormality, there is high risk of structural abnormalities, fetus with abnormal sonography. So there are some correlations which need to be done in the prenatal phase where you will actually pick and choose this patient where we need to do a chromosomal microarray analysis. Again, the indication is if there is a structural abnormality in the fetus, which is identified by the sonography, please do a CMA test. Wherever there is intrauterine fetal death, stillbirth, this test is recommended. Again, there is no indication of what age we need to do this test. This test can be done irrespective of the age, not like a maternal marker test where the indication says likely to be done beyond 35 years, but here any age female can be exposed to this test, which is chromosomal microarray analysis for the fetal health. Anyways, what does it do? It does pick up the chromosomal imbalances in the form of missing chromosome. It will tell you the fetus has missing chromosome, microduplication and microdeletion. All that can be picked up by this chromosomal microarray test. Any unexplained delivery delay, unexplained intellectual disability, autism, I think all that is covered by this test. So this becomes a very interesting tool for all of us to pick up any abnormality happening in the fetal period. Okay, now very basic, I'm sure Dr. Ashish will cover this up, but I think this is where the diagnostic industry is going towards. We have a tissue, we do the biopsy, we have a surgical specimen, it's invasive, you take out the tissue, it's risky, difficult to repeat, you do a histopath testing for this. It's a snapshot of one time over the period and over the space. It's highly sensitive. Histopathology is definitely the gold standard. You need to get the tissue investigated. It's still very, very important. But again, keep one word in mind, which is about the liquid biopsy. What is liquid biopsy? Liquid biopsy is you, apart from doing the tissue biopsy, you also keep on monitoring the status of the patient's health, convalescence, the improvement, the prognostication can be done by doing a liquid biopsy as well, which means you pick up the body fluid, usually blood. It's non-invasive, you take the sample and it's easy, repeatable, although it is low in sensitivity when it comes to first-time diagnosis, where tissue biopsy is the gold standard, but it's easy to repeat, real-time detection, comprehensive cancer monitoring. And it is very, very interesting because you can actually not only pick up the cells, the concept on liquid biopsy is the circulating tumor cells, CTC. The tumor cells are not only in the tissue where the tumor is, but it will also circulate in the blood. It's a very promising biomarker. These are the three biomarkers, T, DNA, ctRNA, and CTCs are the promising biomarkers, which actually talk about the tumor heterogeneity and patient's treatment response. If you are able to pick up the CTCs, you mean that the tumor is still there. So this is evolving. Lot will happen in liquid biopsy. I think there will be a huge transition happening to how the prognostication can be done by using liquid biopsy. I really, really want all of you to be aware of this term because this is where the histopath also is now moving towards. It's also along with the companion diagnostic, which means every cancer, every diagnosis will have a targeted therapy. It becomes very, very important to have a very targeted therapy. Again, the world is moving towards precision diagnostic, which means you need to be precise with the patient. It is patient-specific diagnosis and the patient-specific targeted therapy. So this is going to help. Again, standalone test, you can ask for a number of tests for complex diagnosis, but keep in mind integrated testing is the call now, which means you do have a cross-department test panel. Ask for when you need to close the loop for highly complex cases like myeloma, ITP, MDS, and also about CLL. So this is just the introduction. Ask for integrated testing. Again, One small snippet, I won't take much time. This is all about what need to be done, what need not to be done, although we all are well aware. HbA1c test frequently is asked within 3 months of previous month. Please, let's refrain. Keep it between 3 months and beyond, ideally after 4 months, because that's the time the RBC lifespan takes to change, which is 90 days to 120 days. So we should not be asking HbA1c within 3 months. Also, ANA testing, which I mentioned about, a screening test to pick up autoimmune conditions, should not be done in patients who do not have any symptom. Now, I recently had a patient who was asymptomatic, got ANA done, immunofluorescence. Again, it came positive for some, and we really don't know what was going on with that patient. So ideally, in 20% cases, you can see ANA positivity coming positive in healthy individuals and non-rheumatic conditions. So there has to be an indication before you do ANA testing. Also, I think Dr. Nilima will be more familiar with this and all the gynacs here, but AMH test and all the tests which we do for the ovarian reserve, please do not do it just to judge a woman's reproductive potential. It has to corroborate with some clinical condition and not to just find out whether the female is fertile or not. So H. pylori test, again, antibody has to be stopped or not to be asked for. It's better to do a stool antigen test. Antigen is always better as a thumb rule in any diagnostic testing apart from doing any other test. So it's serology test and then antigen and then comes the PCR. Again, dengue, when to do dengue? A dengue PCR and NS1 test have to be done very early in the period of infection, starting from day 1 to day 5. Actually, day 9 is theoretical, but it works wonders when you do it within 5 days of illness. IgM thumb rule, as I mentioned, is always to be done 5 days and beyond. Now, keep in mind, dengue IgM will persist up to 3 months. Dengue IgG will come much later. Electrophoresis, again, need not to be repeated. You do it once, unless you have a therapeutic intervention plan, not required. So HB electrophoresis have to be done only once and doesn't need a repeat because that will remain the same. Now, this is a word of advice and very, very important is when you ask for a blood culture, please keep in mind you give as much sample as possible, which means one bottle should have at least 10 to 12 ml of blood each, nothing less than that for adult population. So if you give paired, we are giving around 20 to 30 ml of blood, and that's what is the indication so that we are able to pick up the culprit optimally. Again, the future is going towards gene expert MTB XDR, which I mentioned will pick up isoniazid fluoroquinolone. But this test has to be done once you do gene expert ultra. If the test comes positive, you expose it to gene expert MTB XDR, which means that you know that you are able to pick multiple drug resistances in this. This is again recommended by the international TB authorities and guidelines. NGS, next gene sequencing is the way ahead when it comes to infectious disease, oncology, and genetic disease. Microfluidics has also come up, but I think it's little premature to talk about it right now, but lots is happening, lots is happening in diagnostic industry. The entire world is moving towards various new genetic related investigations now, all for oncology, infectious, and other genetic conditions. One update is fasting is not essential for lipid profile. I think we all are aware, but it's important for me to reiterate. So left-hand side, the societies which talk about it, and they all say that non-fasting lipid panel is acceptable. When it comes to Lipid Association of India, European Society for Cardiology, I think it's time that we change our mindset and also ask for non-fasting lipid profiles. Yes, only one value will vary, that is triglyceride, which is again 175 or so. So that is one thing which I wanted to reiterate. Now, this is for Dr. Nilima. Dr. Nilima, as you mentioned in the beginning, there is health package that we have prepared specifically for the team here of AMC. Now, this is our usual one where we give around 70 to 80% discount. I'm sorry, I'm not much familiar with the way I have to show this, but this is only for the females. Only pathology tests, which includes ProSelf Gold for 40 years, ProSelf Gold for 50 years and 60 years, and also for him, which is for the males, ProSelf Gold 40, 50 and 60 years, where the MRP is very high, offer price is low. But what I want to come is this profile, which we have created exclusively for the AMC team, which is ProSelf Easy. As you can see, the MRP and the offer price, probably that's what we are planning to have association with all of you in this. And that's the insight from my side about the ProSelf Easy package created for this team exclusively, which covers anemia, heart, liver, kidney, bone, thyroid, and vitamins as well, of course. So it's easy to do a lot of testing, but this talks about be very, very specific in your approach. If there is a problem in the head, please do not do any test, which means that if you have fever, please do tests related to fever. Don't go here and there. So that's a very basic level of investigation, which has to be very targeted and specific to where the problem is. So this is the phone number. I'm reachable. Please reach me out for any query, anything, any detailing. I'll learn from you. We all learn from each other. So thank you so much for patiently listening to me. Any query, please do let me know about. I think I finished.
Question answer box has a lot of queries, Anupa. I would ask Ashwini, please take up this question.
Yes, madam. Few questions we have in the chat box, like what is the cutoff level of PTINR pre-operatively? Specifically, if the vitamin K is to be avoided in such cases, what is the cutoff point?
So if the patient is on anticoagulant or not anticoagulant, so it depends on that. So on anticoagulant, normally it is 2.5 to 3.5. And below that, 1 to 1.5 is what we consider without. Now, one more thing, INR actually should not be done if the patient is not on anticoagulant.
Okay.
This is done to see the normalized ratio when somebody is on anticoagulant. That's first indication. But again, if somebody is on anticoagulant, it should be high, which is 2.5 and above when it comes to a person who is on anticoagulant. If not, then it has to be definitely lower than that. Again, it will vary from lab to lab. So I would request you go to the lab, see the report, because that reference ranges talk a lot about that.
Okay, this is regarding specifically if the patient is posted for CABG.
Okay, so CABG, again, as I said, every lab will have a different unit, because in a lab, when we do a PT-INR test, what we are supposed to do is we have to establish the normal range. So that will vary from lab to lab. Unless you have a normal range established by running 20 normal healthy individuals, we cannot actually do a PT-INR test with every lot. So that range will vary. And also the ranges mostly is 2.5 to 3.5 for any add-on anticoagulant or vitamin K.
Okay, perfect. Next question is, what is the price difference of rapid and ELISA tests?
Oh my God. So as a thumb rule, rapid tests are very cheap. Cheaper as in like not cheap, but yeah, less in price. But ELISA tests are little marginally priced, but I think the quality says all about ELISA, why we recommend ELISA more than CAR test. Now there is a capping of CAR test, which the government has actually produced and insisted on dengue test. Actually, they recommend we should not be running CAR test at all for dengue. It's all ELISA, which is capped at 600 odd. I don't know whether that has changed now, but this is how it is.
Anupa, I would like to second that, because even though the CAR tests are extremely cheap, all right, and the ELISA tests are far more expensive, in the long run, if there is a case against you, believe me, this will become cheaper and not more expensive. So more specific, patient-specific, symptom-specific, disease-specific tests will even give you the way you're going to treat. And we want to contribute to the non-drug resistant part, because that is our that is what we owe to our patients.
Absolutely.
So once we have specific diagnosis, specific indications for giving specific drugs, we will be able to avoid the multiple drug resistant strains that are coming up. I think it's extremely important from our part that we should be doing the ELISA test rather than the rapid test.
Absolutely, I agree with you completely.
Perfect medical legal touch from Nilima madam, I must say. And the last question is, what are the limitations to the automated tests like CASA?
Okay, so limitation wise, trust me, I spent 1 week finding out whether there is a limitation. I did not find any. Except that it needs some, actually nothing. It's an automated system. The software might get corrupted, but that's a remote possibility, which doesn't happen. It's such a beautiful system. You just introduce the sample to the instrument. It will give you all the details and so much information that you really don't know what to actually share, what not to share. It's so informative. I think the way AI has shaped up our work now, artificial intelligence, and the way automation has come up, I think it's on us to actually make it very useful now. I have not seen any limitation as of now in this. I'll be happy if you can share some.
Okay,
There was
many.
also one query about the troponin levels in the non-STEMI patients. Could you elaborate on that?
So troponin level, the beauty is when you look at this test, troponin I and troponin CHS, you actually you get a cutoff. So whenever you do a test and you get a cutoff, which is rule in, rule out criteria clearly, which is like two extremes, you can actually not think about MI in these patients. But for the ones where you actually feel it is falling within the limit, like 2 and 90 is the range, then you repeat that patient every 2 hourly or 3 hourly, depending on what platform you are using, and see the delta variation. So you are not able to miss out on any condition because there is a algorithm. It's a proper algorithm which has been placed in the picture, and you just need to go with that algorithm. It's very clearly and it corroborates very well. Recently, I had 2 patients where the value came in between, which is like high, but not falling under rule in, rule out criteria. What we did, we repeated after 2 hours. What we found is that the increased delta, which was expected, was not the same as we found in this patient. Some investigation was done and the patient was asked to go home. I think such a beautiful test to pick up. In cases of non-ST elevation and ST elevation, both cases it worked the same. Such a beautiful investigation. There's no panic now. Reliability on ECG is very low now because ECG will only come high or be abnormal when there is acute phase, and also it is 50 to 60% sensitive. ECG also will not be able to pick up alone. But HS-TOPI gives you a good window period for both the types of MIs, and you are able to actually take care of patient in a very beautiful way.
Anupa, your lecture was beautiful, and I insisted on this topic because this is something, as Association of Medical Consultants, we are an umbrella body for all the multi-specialties, and every specialty is doing their own specialty program. But diagnostics happens to be common to all, and all doctors nowadays get patients with pain here and pain there, and we don't know what exactly to do. So at this particular time, to save a patient's life is something we owe, and that is where the troponin test and the other tests that you talk about, come into very, 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 very handy. Anupa, thank you. I'm so sorry. I'm taking away the thank you from somebody else. But my heart is so full, with your talk today. I had missed your lecture during the Kandali Medical Association talk. And that is where, it was there in my heart right from the day I became president that, yes, this is one topic I want to deal with. And we were going to have a physical program, but we had to shift it to a webinar. But I am requesting you, Anupa, to have this talk anywhere and everywhere you go. And if possible, update it every year with whatever is the latest and the newest technologies, because doctors need to know, and specialists especially need to know the latest, because the court also says that you have to update yourself with the latest information. So I guess we should be working towards patient safety and no other goal but patient safety. So cost effectiveness is very important. I will hand over to somebody. One input from my side as a gynecologist is that though NIPT and all has come in, please do not consider the sonography that we do for the NT scan as anything minor. It has to be done. Whether you do a dual marker or you do an NIPT is a different thing. NIPT, yes, picks up earlier, and the dual marker picks up a little bit later. So you have that chance, of doing the abortions at a slightly earlier gestation, which allows the patient also a better health. But the NT itself has more diagnostic and prognostic value. So do not miss out on that. And rest which you said about site-specific TB culture, we have to keep that in mind. Molecular PCR, we have to keep that in mind. Syndromic testing, extremely important. ELISA automation, extremely important. Chromosomal microarrays, please remember something which is new and coming up. Liquid biopsy was a topic I wanted to take up, but Dr. Sevanti could not join us today.
Right.
But it is an absolutely newest thing for prognosis, because this is the one which is going to pick up the cells that come in your blood circulation even before the secondaries get established in the tissues and you pick them up late. So a very, very important topic. Thank you so much. Thank you.
Thank you so much. Thank you so much. This was just half of what we could have presented today. Actually, there's so many things which are still pending. So I'm excited to have it again. Of course.
We could have you once for the whole day.
Thank you. All right. All right. Thank you.
Thank you so much, madam, for such an elaborative talk. Let's move ahead to the second talk of today. I'd like to call upon the digital dais Dr. Gautami Bhatkar, and she will speak on do's and don'ts of histopathology. Dr. Gautami Bhatkar is currently working as histopathology department, Suburban Diagnostic, Vidyavihar, West Mumbai. September 2019 till November 2020, she was clinical associate in histopathology at SRL Diagnostic, Goregaon, West Mumbai. And July 2018 to July 2019, pathology house officer in KB Baba Hospital, Bandra West. June 2015 to June 2018, she has worked as a resident in pathology laboratory, histopathology, cytology, and blood bank for 3 years in from KNP Salvi Institute of Medical Sciences, Nagpur. Welcome, madam.
Warm good morning to everyone. Thank you, Doctor. I'm pleased and thankful to be presenting on this platform. So today's topic is, I'll just share my screen near 2 minutes. Yeah, I think you can see the screen.
Yes, we can.
Yeah, we can.
Yeah. Okay. Thank you.
When you go to the screen share.
Yeah. So today's topic is do's and don'ts in histopathology and cytopathology. So today's contents are introduction about a detailed version of biopsy, cytology, microscopy and reporting, and some quality parameters that we practice. So pathology literally translates to the study of suffering. It's from Greek word pathos, which is suffering, and logos, which is study. And the term pathology is invoked to represent the study of disease. Histopathology is one of the section in pathology which is study of microscopic study of tissue, and cytopathology is examination of cells from bodily tissue or fluids to determine a diagnosis. I've just put a picture of Dr. Rudolf Karl Virchow. He's known as father of modern pathology. So coming to biopsy, I'll be talking about the definition, indication, the types of biopsies, care taken of the biopsy, the procedure that we do in laboratory, and a few mention about some special biopsies. So biopsy is removal of body tissue from for various purposes. The most common purpose is diagnostic, and it is also removed for therapeutic purposes, like in cases of appendicitis where an appendectomy is done. So these are the various indications of it. The first is confirmation of diagnosis, and I'll just have put an example wherein there's an enlarged lymph node patient presenting with fever, weight loss, and on microscopy there's these caseation, necrosis, epithelioid granulomas, Langhans giant cells, typical of tuberculous lymphadenitis. So in this case, we just confirmed it that this is a tuberculous lymphadenitis. The other indication is exclusion of differentials. An example here is an ovarian cyst. So the differential could include a hemorrhagic corpus luteal cyst and an endometriotic cyst, and in some rare cases an ovarian ectopic gestation as well. So on microscopy, you can see that this is a cyst aligned by endometrial type cells and showing alveolar macrophages, very characteristic of endometriotic cyst. Then to exclude other diagnoses where clinically a patient presents with appendicitis and an appendix is removed and you see features of appendicitis, but incidentally a carcinoid is being found in the appendix. So even when the diagnosis is confirmed, we still insist on sending these samples for histopath so that any incidental tumors can be diagnosed. Then the other indication is to assess the clearance of excision margins in cases of malignancy. So here is a picture of a WLE of a tumor wherein the margins are tagged. In histopathology, we inked the margins and take sections accordingly. So here is an uninvolved margin where the tumor is not reaching the inked margin. But on this section, here you can see those tumor cells reaching the inked margin. So this is an involved margin. The other indication is grading of malignancy. Tumor cells are graded based on their differentiation, the nuclear ertypia and mitosis. So this is a well differentiated tumor, a moderately differentiated tumor, and a poorly differentiated one where there is a lot of nuclear pleomorphism or nuclear ertypia. It's also done for staging of disease, like lymph nodes are removed in case of resection samples. And here you can see this is a normal lymph node and there's a metastatic deposit seen. So this upstages the stage of malignancy. Biopsies are also done in cases of theranostic purposes, example being of breast biopsy and with immunohistochemistry where ER/PR is done, estrogen and progesterone receptors, and this is used for theranostic purposes. So coming to the types of biopsies, we have mucosal biopsies, which are endoscopically and colonoscopically taken and ideally should be sent on filter paper in 10% neutral buffered formalin. The other type is a punch biopsy, which is skin punch biopsies are usually done, which are approximately 3 millimeter in size and should have a bit of subcutaneous fat when a lesion is suspected in the subcutaneous fat. Other biopsy is a needle core biopsies. Core biopsies are usually of length 11 to 12 millimeter are adequate, and these should contain more of the lesion and less of the fat, especially in cases of breast tumors. Curatings, endometrial curatings are usually sent for cases of AUB, DUB, even POCs. Then tissues are excised, like mass and cysts are excised for and sent for histopathology. Then there are resection specimens, complex resection specimens for malignant tumors. Nephrectomies, hysterectomies are done for benign conditions like non-functioning kidney or fibroid uterus. So there's some care to be taken out for these biopsies that before and during the procedure, avoid contamination and avoid artifacts, contamination with extraneous material or tissue from another patient. Then some artifacts can be prevented while during the procedure. There are cautery artifacts that are seen. I'll just show a picture. This is glands which are, because of the cautery artifact, these cells are they resemble malignant cells. But this is a cautery artifact which gives a corrugated and toned appearance. So cutting electrode is used instead of a coagulation electrode to avoid this artifact. Similarly, forceps or traumatic forceps can be used because they cause forceps artifact causes these tears in the tissue. Then there are injection artifacts wherein because of injection of anesthetic into the tissue, into the lesion itself causes separation of connective tissue. So we can avoid this by avoiding injecting the anesthetic into the lesion. Then some points to be kept in mind after the procedure, that is immediate fixation, placing the tissue in leak-proof appropriate containers, care with multiple samples, and when there are sharing samples, what other care must be taken. And one more important thing is a completely filled requisition form. So fixation, immediate fixation is essential as it prevents cells and preserves cells and prevents autolysis and putrefaction. It is done by adding adequate amount of 10% neutral buffered formalin to the tissue. Ideally, the amount of formalin is 20 times the volume of the tissue. So number of samples, we keep a record at Suburban as number of samples received without formalin, as it is a indicator of quality. It's a pre-analytical indicator and it affects the quality of tissues. And we strive to keep this number as 0 by educating the centers and providing formalin. Last month, in the month of November, we had 5 cases that were received without formalin. So containers are a little bit about containers. Like containers should be properly labeled with at least 2 identification labels, either the name, age, sex of the patient, or just an sample ID. Then the container should be leak proof, should be large enough to accommodate the specimen and filled with enough formalin to completely cover the specimen, and should have a large opening so that the tissue can be easily removed, because when the tissue are removed from the patient, it is very pliable and easily placed into containers, but after fixation they get hard, and it's very difficult to remove such specimens with from narrow opening containers. And please do not send samples in gauze pieces, because while retrieving the sample, some tissue may get lost or they may be crushed. So these are the I just put pictures of wide mouth containers, and formalin is placed in this container, and you can place cotton over the tissue so that it doesn't float, and there is appropriate fixation of tissue. Please do not use narrow mouth containers or gauze pieces. So when there are multiple biopsies from different sites, it's always good to send in separate containers. If not, tag it accordingly and label it accordingly. So there's always a difficulty in sharing samples are shared for multiple tests, including histopathology, microbiology, clinical pathology. So whenever there is sample sharing, see to it that the sample sent for histopath is always in 10% neutral buffer formalin, so that the tissue is not autolyzed. Also, when in there are necrotic tissue that is sent for culture sensitivity as well as for histopath, if there are some soft tissue pieces, you can always send it those soft tissue for histopath. Requisition form has to be filled completely filled. Requisition form is a must because it helps in the correct diagnosis. The various points in the form are tissue identification, site of biopsy, the orientation, which all especially in cases of malignancy where margins are assessed. The fixative used, normally formalin is the preferred fixative, and details about the chief complaints, that is symptoms, the duration of the same, always helps in arriving at a correct diagnosis. A brief history of current medications is important, so that because medications also affect the cells, then previous surgery or medications, so that a recurrence of disease can be considered. Clinical provisional diagnosis, differential from clinical point of view, is always helpful. The date and time of procedure done, if it is mentioned, is very good, because we can know the exact fixation time, and this is required if any ancillary test like immunohistochemistry can be done, so that we know that the effect of fixation time is proper. And always it's helpful to have details of doctors on the requisition, because some cases need discussion with the clinicians. So just a brief about the procedure at our lab that we do. After receiving the sample, the tissue are grossed, then the sections are taken, tissue is processed, embedding, cutting, and staining, and lastly reporting. So grossing, after the tissue is received, it is registered and fixed for adequate time, which is usually 6 to 72 hours, depending upon the size of the tissue. And it is then grossed after describing the tissue, giving macroscopic examination, and taking sections which are about 3 to 4 millimeter in thickness. So this is a grossing station at a suburban diagnostics. So there are some do's and don'ts that are followed in the grossing station. That is, the samples are to be fixed immediately. Large specimens are cut fixed according to standard protocols like an MRM or nephrectomy specimen. Then the fixing and grossing of one sample at a time. Cleaning of knives, blades, cutting boards, forceps after each specimen, and labeling of cassettes with pencil. Some don'ts are the do not fix samples more than 72 hours. Sections should not be more than 4 millimeter thick. Cassettes are not marked with a pen or a marker, and the same type of tissue, like example endometrial tissue, are not grossed consecutively. There is always a different sample which is taken between two similar tissue samples. Next is the tissue processing step, wherein the tissue goes through fixation, dehydration, clearing, and impregnation. So this is an automated tissue processor. Then the next step, after the tissue is processed, it is oriented in melted wax, and such blocks are prepared. These provide a firm media for the tissue and helps in cutting of the tissue, which is done over a micro toe. These are the ribbons of tissue that is cut. Then the sections are then placed on slides and stained accordingly. The routinely taken stain is hematoxylin and eosin, but we have some special strains like AFB for tuberculosis, wherein here you can see these AF acid fast bacilli. There are past stain, GMS stain for fungal also that we routinely do. So care during the tissue processing is that one specimen at a time, cleaning of forceps after each specimen, labeling of blocks and slides, at least two identification points, that is the name of the patient and the biopsy number. So coming to special biopsies, we have certain special biopsies wherein we have kidney biopsy with direct immunofluorescence, skin biopsy with DIF, bone tissue, and reflex biopsies with IHC. So at Suburban, we process transplant and kidney biopsies along with direct immunofluorescence. Kidney kits are provided with 10% neutral buffered formalin, Michel's media, and 3% glutaraldehyde for light microscopy, DIF, and electron microscopy, respectively. Transplant kidney biopsies are processed immediately within a shorter processing time, that is 6 hours, and a timely report is given. So this is our renal biopsy kit having formalin, Michel's media, and glutaraldehyde. Again, skin biopsies are processed here, evaluated for various dermatoses. Again, immunofluorescence is carried out especially for pemphigus cases. The bone tissue are special because they cannot be processed directly as the calcium salts render them hard and they need a decalcification before processing. Decalcification do take time and leads to delay in reporting. In obvious bone specimens, decalcification does take a lot of time, like mandibles and head of femur. But when there are certain calcification noted, especially in dermoid cysts, like in Rokitansky protuberance or a calcified fibroid, they do to take decalcification and result in delay in reporting. We have reflex biopsy with IHC. Basically, these where malignancy are detected in biopsy, we carry out IHCs. The most common panel is a breast panel, wherein after breast core biopsy is detected as malignant, the IHCs carried out are ER-PR, HER2-neu, and Ki67, which have both prognostic and theranostic markers. The other tissue is a lymph node biopsy, which with the reflex IHC to detect lymphoma and phenotypically categorize it. We have extensive list of IHC markers, which include all diagnostic, prognostic, theranostic markers. A special mention of C4D IHC, which is routinely used in renal transplant biopsy as it is mandatory in detection of antibody-mediated rejection. Coming to cytology, cytology is examination of cells from bodily tissue or fluids. Advantages of cytology include it's a simple technique, it's rapid, economical, avoids further tissue biopsy in case of inoperable malignancy or infective conditions. However, they do have limitations, which is there is loss of architecture. In capsule invasion or lymphomascular invasion is not possible, especially in thyroid nodules, wherein the differentials is between a thyroid adenoma and a follicular carcinoma. And it's also very difficult to comment on in situ versus invasive carcinoma. So the various tests that we carry out are gynecological, liquid-based and conventional smears, body fluids, all pleural, peritoneal, pericardial fluids, respiratory, including bowel fluids, sputum, GI brush cytology, and fine needle aspiration cytology. Care of samples in cytology, especially when it is pap smears, conventional smears are not preferred because there's difficulty in spreading the smear. It is advised that the smears are spread as thinly as possible, and these are immediately fixed in alcohol because they cause drying artifact. Just picture of a normal pap smear here with the cells of ectocervix and neutrophils. But here this is a conventional smear causing complete overlapping of cells. And here you can see this drying artifact, which is because of not uh, fixing the slide immediately. Then some care of body fluids is again, these need to be sent immediately for processing to prevent degenerative changes. And if there are clot present in fluids, we can always send that across and we can prepare cell block from them. Urine cytology, 3 consecutive days sample is preferred in cases of suspected malignancy. Again, it's the early morning freshly voided urine which is required. Then the procedure that we carry out is staining of pap smears with pap stain. Fluid samples are centrifuged and then smears are prepared, and routinely stained with hematoxylin, neosin, PAP, and GIMSA stains. And cell blocks are prepared wherever applicable, especially if malignancy is suspected or it's an elderly patient. Microscopy and reporting, while microscopy slide number and name are checked against the worksheet, standard protocols and guidelines are followed. Example, Gleason scores for prostatic adenocarcinoma, Bethesda system for pap smears and thyroid cytology, and Paris system for urine cytology. And if there is any unexpected findings, we immediately inform the clinician, especially findings that impact the treatment. And again, if any ancillary tests like IHC or molecular studies are required, the same is conveyed to the clinician. So this is a picture of a report where we have given a synoptic report, and all these points are required as per CAP guidelines. We have certain quality parameters that we strictly adhere to at Suburban, which include TAT, the turnaround time, the ASIL ratio, which is for pap smears, correlation of SIL, that is squamous intraepithelial lesions, with HPV testing, and correlation of cytological and histological findings. So the turnaround time at Suburban, we strive to provide correct and timely reports. Our TAT percentage for November month was 89.8%. The reasons for delay in TAT are basically because of lack of clinical history, decalcification, more sections which are taken after any incidental findings. Around 2.7% cases were delayed due to inadequate clinical history provided in the month of November. Suburban being a CAP accredited lab, the quality is maintained as per CAP guidelines, and one such parameter is the ASIL ratio, that is a typical squamous cell to squamous intraepithelial ratio in pap smear, as it gives quality in reports, as the gray area of ASCIS needs to be limited. So the ratio is around 2.1%, which is within the recommended range by CAP guidelines. The quality parameters include correlation of SIL cases with HPV testing. So in the month of October, November, out of the HSIL reported high-grade squamous intraepithelial lesions reported cases, 60% cases were positive for were tested for HPV, and all those cases were high-risk HPV positive. 40% cases were not tested at all. So we have correlation with cytological and histological findings that is done as well. So there are 96% cases of cytological findings who are concordant with histopathological findings. And the reasons for non-concordance may be due to inadequate or non-representative samples. That's it. Thank you so much. If there are any queries, I'll be glad to solve them.
Ashwini, would you please ask the questions that have come in the question box? Hello.
Yeah, so
Okay.
I'll take it up with Dr. Gautami. Dr. Gautami, the question is, could you please give recommendations on best practices to avoid cautery and forceps artifacts?
Yes, sure. The cautery forceps, electrode forceps are to be avoided. You can use electrodes are avoided. Rather, you can use a cutting forceps. Even traumatic forceps can be used. And even while placing the samples, after placing the samples in formalin, avoid using traumatic forceps. Blunt forceps can be used for the same.
Gautami, your lecture was a much needed lecture according to me, because a lot of times doctors take a lot of efforts to collect samples and to collect biopsies and to collect cytology samples. But our staff sometimes does not know how to handle this.
Yes.
We cannot instruct our staff unless we ourselves know it. And I always believe that we have to correct ourselves first before we correct anybody else. So the entire essence of having this talk was for doctors to understand what to and what not to do. And you have brought it out really, really well. we also understand that the labs have their own limitations of sending a report. And this point was brought out by you very nicely as to why sometimes lab reports get delayed. And we do appreciate that we are now trying to understand your part of view, because I remember calling every time, "Arey, abhi tak report nahi aaya, patient is, getting hyper." So we should be able to deal with patients now with the light that you have thrown on why pathology reports can sometimes be late. So thank you very much. And doctors attending today, please remember that your requisition form along with the sample is extremely important. So patient history, very important. Name, age of patient, very important. Where gynecological samples are concerned, the last menstrual period, whether the patient was hysterectomized or not hysterectomized, whether the patient is menopausal or not menopausal, the hormonal medicines that the patient may be on, all that is extremely important because all these things affect the histopathology. So thank you very, very much. And we move on to our next topic now. Thank you.
Thank you, ma'am. Thank you so much.
Dr. Ashwini, I would request you to now go on to our next speaker. Anupa, would you take this forward? I think Ashwini is logged out or something.
Sure. Sure, I'll
right.
do that.
Thank you.
So our next speaker is Dr. Vineet Nair. He's a part of my team and he's heading our Goa laboratory, and he's also taking care of our medico marketing and the content activity. So he's a very important key person in our team. And his areas of interest are clinical research, biostatistics, and hematopathology, clinical pathology, lab core, basically, and nephropathology. I think it's a long list. But he is also very well and very experienced when it comes to the content creation and the medico marketing aspect, which I mentioned about. So he is passed all his exams from Kozhikode. I don't know whether I'm able to pronounce it properly, but it's a Calicut University. And he is he has plenty achievements under his experience. He's a very well experienced person when it comes to a lot of achievements in various aspects. So I will introduce Dr. Vineet to come and talk a small bit and introduce us to the metabolic syndromes. So welcome, Dr. Vineet.
Thank you, ma'am, for that introduction. I was very lucky to have you introduce me. So I would say, because it's still 10 minutes before 12, good morning, everyone. Today, I'll be taking you through a little bit on biomarkers in metabolic syndrome. So this is going to be more of a glimpse into the next 10 years, what you can expect in the next 10 years. I'm not going to be dealing with the usual HbA1c, fasting, blood sugar, and all of that. This is going to be something a little ahead of what you're usually used to. So I hope everybody can see my screen. So I'll start off quickly because I don't want to overstep my time. When we're talking about metabolic syndrome, so the first thing that we realize is there is, even though there's a broad idea that metabolic syndrome includes, central truncal obesity, it has atherogenic dyslipidemia, insulin resistance, and also hypertension. The clinical definitions given by the various organizations do vary here and there. As you can see, the NTP guidelines, the International Diabetes Federation guidelines, the European Group for Study of Insulin Resistance, the WHO, the American Association of Clinical Endocrinologists, all hit the same points that I mentioned, but their criteria differ slightly. So for the purposes of this presentation, let's just assume that when we're talking about metabolic syndrome, it's a constellation of its symptoms, which include truncal obesity, insulin resistance, atherogenic dyslipidemia, and hypertension, right? There are other names that this is known by. It's also known as syndrome X, insulin resistance syndrome, the deadly quartet, obesity dyslipidemia syndrome, and sometimes also known as the hypertriglyceridemic waste. So the pathogenesis, the pathophysiology of metabolic syndrome is highly complex. There are, modifiable factors, environmental factors, genetic factors, all included in it. But simply put, I found this is a more easy way of looking at the latest, knowledge regarding the pathophysiological mechanisms in metabolic syndrome, and you may see some of these names later in the presentation as well. But the main thing is we have overeating, physical activity leading to visceral or truncal adiposity, which leads to increased cytokines being released by the adipose tissue. The angiotensin type 2 receptors being activated higher, leading to reactive oxygen species being generated. The lectin-like oxidized low-density lipoprotein activation. There are inflammatory markers like CRP, IL-6, TNF, which are all released in bigger numbers, and also very fatty acids in the blood. All of this generally leads to neurohumoral activation, chronic inflammation, insulin resistance, leading to what we know as metabolic syndrome. So the present, we have certain established markers that we do test for. As you may have seen in the table that I presented regarding the clinical definition, there are certain markers that we do look for, right? There's HDL, we look for triglycerides, basically the lipid profile. We also look for abdominal circumference or BMI. We look for, other markers such as for insulin resistance and all, but these are established markers. What I'm going to be talking today is a little more experimental in the future, still in the research phase, but many of these markers are things that you will feel very familiar with. There are many of these which you will feel familiar with. So these are the present that are used to monitor or to predict or diagnose by metabolic syndrome. But the future, as I said, there are a lot of markers. There's a huge cloud of markers that have been tested. For this presentation, when I was looking it up, I found there are in excess of 45 to 50 different markers currently being tested and researched on worldwide. So I'm not going to hit all of them, obviously, but these are the ones that seem to show the most promise and that need discussion currently, because many of these are likely to be included in the guidelines or in your daily practice in the next couple of decades as you come. So I'm going to broadly classify these into dyslipidemia markers, oxidative stress markers, inflammatory markers, adipokines, and one very unfamiliar new other marker also, which doesn't fit particularly to any of these categories, right? So let's start with dyslipidemia markers. So the first one that we're going to talk about is apolipoprotein A1 and B. So ApoA1, it's a structural protein found in HDL, and it plays a major role in the transport of cholesterol by moving it from the tissues to the liver. Now, ApoB is also a structural protein, it's structural lipoprotein, and it's found in each chylomicron VLDL and LDL particle. So ApoB constitutes a large proportion of the total protein in LDL. Now, what we found is that ApoB/A1 ratio is higher in metabolic syndrome, and multiple studies have shown that it's a good predictive marker of metabolic and pre-metabolic syndromes. It's also associated with carotid artery intima media thickness, and it's just an early marker of atherogenesis and a risk factor for MI in older adults. So you may have seen this particular parameter ApoA1B in health checkup packages. It's been popping up in health checkup packages and cardiac risk packages over the past decade or so. Now, this is another parameter which is similar to ApoA1B. Again, you will see this in many cardiac risk markers and panels throughout the world. It's called LPA or lipoprotein A. It's an LDL-like particle which has an ApoA bound to an ApoB100 with a disulfide bridge. Right now, this particular marker has been seen in recent literature to be higher in people with metabolic syndrome and is associated with increased pro-inflammatory status in newly diagnosed metabolic syndrome patients. Now, the thing is, this has also been used by cardiac physicians to estimate cardiac risk. It's one of those parameters that's coming up for that. However, it's slightly controversial because LPA levels are mostly related to your genetics. It reflects your genetics more than anything. So it's not very modifiable, though some studies have shown that giving niacin can reduce its levels, but it's usually not very modifiable. And its plasma concentration is also affected by various pathologies, hormonal factors, individual and environmental factors, such as pharmaceuticals and therapeutic procedures. So whether LPA will end up being a biomarker in the future for metabolic syndrome is something to be seen. But as of now, it is one of those major markers that have been tested as far as dyslipidemia markers are concerned. So let's move on to some more common ones that we've seen. These markers represent the oxidative stress portion or the pathophysiological pathway in metabolic syndrome. So uric acid. Everybody knows uric acid. Probably everybody does do it. We see, especially diabetes patients, obese patients, we do test for uric acid quite often. It's tested in many of these health checkup packages as well. Now, it's been positively associated with obesity, metabolic syndrome, type 2 diabetes, and CVD. Now, this is not news. This has been there in the past. But now, even though in the past it has been considered to be secondary to hyperinsulinemia, recent evidence is supporting that there's a primary role for uric acid in mediating metabolic syndrome, that it's a independent risk marker, not just secondary to the components of metabolic syndrome. So in a cross-sectional study, they found that the prevalence of metabolic syndrome was around 18.9% for uric acid less than 6, and for 8 to 8.9 it was 59.7%, and 70% for uric acid levels which are greater than 10 mg per deciliter or higher. So the increasing trends also were seen to persist in subgroups adjusted by sex, age, alcohol intake, body mass index, hypertension, and diabetes. So again, pointing to the fact that it may be an independent risk marker. A prospective cohort study done in a Korean adult population also showed a high uric acid level could be a positive predictor for metabolic syndrome. And this was for a study that showed a 2.6-year follow-up. So simple point, uric acid, not just a bystander or a casualty in the war for metabolic syndrome. It may actually be a hidden marker for as an independent risk marker. GGT is again a ubiquitous enzyme that's been seen in human tissues. You find it as part of our liver function testing. It's seen in kidney, pancreas, liver, spleen, heart, brain, and it also has a role in the antioxidant pathway in the human body. Right now, it has been studied as a predictor of metabolic syndrome, diabetes, hypertension, and stroke risk, and is being used traditionally or classically as a biomarker to evaluate alcohol consumption and hepatobiliary disease, right? And it's also sometimes used to identify whether ALP rises are due to bone or liver. If you find a GGT and ALP rise together, it's usually liver associated. So GGT is classically being used for liver associated conditions. But now we've seen that elevated GGT is not just a correlate of cardiometabolic risk, but it also may have a direct pathophysiological role via its role in the antioxidant defense. So elevated GGT usually shows low antioxidant defense, increased oxidative stress, which lead to increased cardiometabolic stress and cardiovascular disease, diabetes mellitus, eventually leading to metabolic syndrome. So what are the evidence for that? There was a cross-sectional analysis which has suggested the cutoff value for GGT for metabolic syndrome was 27 for men and 17 for women. But let me just reiterate, this was just one study. There has been no consensus guidelines put on this. So we can't use these cutoffs currently as a reference range or whatever, but this is for your personal guidance, for your personal edification. Now, increased serum GGT could predict the onset of metabolic syndrome and the occurrence of CVD and death above and beyond traditional cardiac risk factors. What was seen was the people with the highest GGT was seen to have a 67% increase in CVD. A study done in India found that GGT also has a role in increasing oxidant stress, leading to inflammation and the development of metabolic syndrome. So like uric acid, what we thought was something that was secondary to metabolic syndrome may actually be a marker that can be used for the prediction of the onset of metabolic syndrome. Now, this may be a parameter which you're not very familiar with, OX-LDL, also oxidized LDL. Now, LDL particles in the body undergo a series of oxidation processes which result in reactive oxygen species and oxidized LDL particles, right? So these OX-LDL trigger inflammation and cause endothelial dysfunction due to its cytotoxic effect. Atherosclerosis obviously is one of the main alterations caused by metabolic syndrome, and endothelial dysfunction is the earliest event in that. So you can see that there is a correlation or there is a connection there. OX-LDL causes endovascular endothelial damage, and endothelial dysfunction is the earliest event in metabolic syndrome. And quite recently, if you remember the chart that I had showed, the table for showing the pathophysiology of metabolic syndrome, soluble lectin-like oxidized LDL receptor 1 is being added to the list of mediators of endothelial dysfunction in patients with metabolic syndrome. There are lots of studies on it. One study had showed that by Howitt et al. In 2008 showed that patients with metabolic syndrome had higher OX-LDL values, hyperinsulinemia, and impaired glycemic control associated with increased OX-LDL values were independent from lipid levels. And elevated OX-LDL levels can predict the development of metabolic syndrome in the future. Kelly et al. In 2010 showed that it correlated positively with BMI, body fat percentage, waist circumference, percentage of trunk fat, abdominal visceral fat, abdominal subcutaneous fat, and with insulin resistance. So, a big chunk of metabolic syndrome is truncal obesity. Most of the pathophysiology starts from there, and OX-LDL is positively correlated with it. Another study in 2017 showed that it is positively correlated with metabolic syndrome and its components even after adjustments for central obesity and insulin resistance. So it may be an independent risk marker, and it also has a strong association with triglyceride values. Now, while in India, OX-LDL is not a parameter which has been used as a risk factor, other organizations, other diagnostic companies, and other diagnostic providers in the US and other Western countries have started giving OX-LDL values with a risk stratification. If I remember correctly, the stratification is less than 60 units per liter would be considered as low risk, 60 to 70 would be considered moderate risk, and more than 70 to be considered as high risk. This is in units per liter. There are multiple units which are used for this, but in units per liter, this is the one that's there. But in India, as of now, this is not in the mainstream yet. And hopefully this is one of the parameters that will be used in future when it comes to predicting the metabolic syndrome, though this test is available in India. When you're looking at inflammatory markers, most of these are, again, familiar suspects for you. HSCRP is something that cardiac physicians and general physicians still use to this day. It's associated with metabolic disease, including dyslipidemia, diabetes, and metabolic syndrome. Now, there's this very robust study that was done on 14,719 women over a period of 8 years, which showed that HSCRP works as a prognostic factor on subsequent risk at all severity levels of metabolic syndrome. And in this cutoff, the study, the cutoff point for CRP to differentiate between high risk and low risk was found to be 3 milligrams per liter, which is similar to the cardiac risk cutoff that is given in labs today in India as well for HSCRP. Many researchers have attempted to including HSCRP as an additional diagnostic criteria. Now, this is one of those criteria which is most likely to come into the diagnostic criteria soon. However, the molecular implications of HSCRP in metabolic syndrome has still not been elucidated, and nowadays, given the kind of research that is done before a guideline is made, every aspect of one particular parameter or one particular assay has to be seen. And when you're talking about an analyte like CRP, they need to know how it is affected in any way, or how it affects metabolic syndrome in any way, even at a molecular level, before they start putting it in guidelines. But we can expect HSCRP to be one of the first to be included in the guidelines in the future. In the previously mentioned women's health study, they found that HSCRP levels, when stratified between less than 1, 1 to 3, and more than 3, they were able to successfully differentiate women with metabolic syndrome into low, moderate, and high risk groups. Now, as I said, this is very similar to the cutoff that is used by cardiac physicians nowadays, and which is given by labs for HSCRP screening as a cardiac risk marker. Cystatin C. Now, this is something out of left field. Cystatin C is also a sensitive marker of kidney and cardiovascular function. It was found that it's higher in metabolic syndrome patients than in non-metabolic syndrome patients, and it is independently of creatinine clearance, or even when creatinine does not exceed the normal. So let me just reiterate that. Even when creatinine is normal, cystatin values are higher in metabolic syndrome patients. So that can be used to kind of, screen out if you are suspecting, if you have a reason for testing for cystatin C. A prospective study done in Sweden showed that high levels of cystatin C can predict metabolic syndrome. Very recently, it was claimed that cystatin C may not only play a role in the diagnosis of CAD, but also serve as a marker of the severity of atherosclerotic disease. This is another, enzyme that is a biomarker that's newly come out, LPPL-A2. Again, it is available in India. It's a novel inflammatory biomarker, and it's associated with metabolic syndrome. And elevated LPPL-A2 activity may identify especially high-risk individuals. It's expressed in greater concentration in advanced atherosclerotic regions than in early stage lesions. So it's a parameter that you can use to kind of track, the stages of an atherosclerotic plaque, or whether there is a plaque formation going on. it has demonstrated substantially less variability than HSCRP. So it may be considered to be, even though it's a new marker, it's very, very new. HSCRP has been around for decades now, but LPL2 is a newer marker, but it's showing substantially less variability and is not elevated in systemic inflammatory conditions. Now, this is where it's more superior to CRP, because HSCRP there can be some confusion if there is an underlying inflammatory or systemic inflammatory condition. It appears to be a more specific marker of vascular inflammation, and elevated baseline risk of LPL2 has been correlated with increased cardiovascular disease risk. And that is even after adjustment for risk factors. So again, this is an independent risk factor, assay that is showing a risk estimation. IL-6, now this came to the forefront a lot during COVID. This may not be a very specific one, but it has been shown that it has a lot important roles in acute and chronic inflammation. There's a lot of study going on regarding the use of IL-6. Studies have confirmed that IL-6 is correlated with all 5 of metabolic syndrome components. One study showed that higher IL-6 levels within hepatocytes in a state of chronic inflammation could be a determining cause of metabolic syndrome development. Another 2 studies found that IL-6 is associated with hypertriglyceridemia, fasting plasma glucose, and hypertension, and that increasing levels of IL-6 are correlated with metabolic syndrome severity. Now, there are studies still going on about how you can stratify this and what kind of increase and at what range or level we should be looking at these values, and what should be the boundaries for this, because IL-6 is also an inflammatory marker. So you may not see IL-6 immediately in the future regarding metabolic syndrome. TNF-alpha. TNF-alpha has been implicated in the pathogenesis of metabolic syndrome. It's an inflammatory cytokine produced predominantly by macrophage cells. It increases CRP levels and determines insulin resistance by interacting with the insulin receptor. It plays an important role in regulating lipid metabolism, cholesterol metabolism, and adipokine synthesis. One study showed that TNF-alpha had higher levels in obese patients and positively correlated with BMI and waist circumference. TNF-alpha is also currently being studied as a possible marker. One study in 2005 concluded that obesity, systolic blood pressure, and serum insulin levels positively correlated with the TNF-alpha gene, and that obesity induces a systemic inflammatory response, and TNF-alpha is an inflammatory marker that determines dysfunctions of macrophages and adipocytes and inappropriate cytokine production. As a result, higher levels of TNF-alpha determine insulin resistance through various mechanisms and promote disease progressions in patients with metabolic syndrome. Simply put, high levels of TNF-alpha may even be responsible for insulin resistance going forward, and through various mechanisms can promote the progression of patients to metabolic syndrome. So this is why TNF-alpha is being investigated as a potential biomarker for metabolic syndrome. Now, moving to the more accepted of all these, the more accepted and the more promising of the biomarkers that we'll be discussing today. Leptin is a hormone that's produced mainly by the adipose tissue. It's considered to be an adipokine. There are multiple studies over the past 2 decades which show that leptin is strongly correlated with BMI, and it's the most sensitive marker for predicting metabolic syndrome. There is elevated leptin in metabolic syndrome women. Leptin is strongly correlated with waist size, and serum leptin levels increased as the components of metabolic syndrome. Thus, reduction of leptin may actually be protective. So it may actually also be a marker that you can use for therapeutic targets. Now, I'll come back to leptin, but just to talk about adiponectin as well. In normal patients, adiponectin is an adipokine. Okay, it's a cytokine that's produced by the adipose tissue. In normal subjects, adiponectin has an important physiological function, maintaining the metabolic balance. Adiponectin levels, therefore, in patients with metabolic syndrome are decreased. Now, till now, whatever we've spoken about, they've all been basically we have talked about parameters which increase for metabolic syndrome, which have a positive correlation. Here, for the first time, we're talking about something that has a decreased or a negative correlation with metabolic syndrome. So it has, in metabolic syndrome patients, adiponectin levels are decreased. Multiple studies have demonstrated the correlation of adiponectin with metabolic syndrome independent of BMI. There is also a strong negative correlation between adiponectin mRNA and CRP mRNA expression in human adipose tissue, suggesting that a decrease in adiponectin leads to a rise in CRP. So it may be involved in the pro-inflammatory process or the mild chronic inflammation that's seen throughout the metabolic syndrome physiology. So more than leptin or adiponectin, what is seen is leptin-adiponectin ratio is a very promising marker going forward. It has increased predictive power despite determining leptin and or adiponectin alone. This is a much better marker. One study demonstrated that leptin and adiponectin interact with each other in order to modulate the risk of diabetes. LAR is also a useful marker of insulin non-diabetic results. And 3 or 4 studies have also shown the correlation between LAR with all 5 metabolic syndrome components. So leptin adiponectin ratio, something that you can maybe that may be a promising marker for metabolic syndrome. Again, leptin, adiponectin, both are markers which are available in India. Ghrelin, this is a peptide hormone that's produced in the GI tract. It's inversely associated. So like adiponectin, it's a negative correlation, and progressively lower ghrelin levels are being correlated with its severity. There is a correlation that has been proven by studies for low ghrelin levels in obese patients when compared to non-obese patients. And multiple studies have shown that ghrelin and metabolic syndrome have a negative association, that low levels of ghrelin may be predictive of or may be able to used to monitor metabolic syndrome. Now, finally, this is a very, very new marker, but I thought that, maybe most of you may be interested, is platelet HDL ratio. There was a recent study which found that platelet HDL-C ratio correlated with all cardiometabolic features of metabolic syndrome, HSCRP, insulin resistance, chimerin, and leptin. So what they found was platelet HDL ratio is significantly increased compared to controls following adjustment for waist circumference. It correlated with all features of metabolic syndrome and increased with increasing severity of metabolic syndrome. Now, unlike the other markers that I've talked about, this there has not been much research on this. There is a lot of scope for it, and because it's a very ubiquitous test, it's a very simple test, it's a very cheap test, this would be something that could that could warrant a lot more research in the future. So I just thought I'll just put that out there. So what are the other markers that are currently being studied? Again, the future, as I mentioned, beyond what the markers, because all the markers I've discussed right now are the ones that doctors are prescribing or testing or checking out, or they are basically there's a lot of study gone onto it, and people are they've already acknowledged that okay, these markers may be useful. It's just that they've not reached the guidelines. There are other markers which are still in the research phase now: free fatty acids, GPX, selenium, paraoxenase, serum amyloidase, sialic acid, IL-10, osteoprotogerin, CD40 ligand, pentraxin 3, exotaxin 1, chimerin, resistin, visfatin, A-megalin, albumin. There are a lot of markers that are coming. As I mentioned, there are in excess of 40 to 50 that I found, which are under research right now, which people are looking at. So what are others? Let's going again, as Dr. Anupai had mentioned, everything's going into the molecular level right now. So what are the other kind of newer out of left field biomarkers that are being looked at? So extracellular vesicles, which are these lipid-bound vesicles secreted by the cells into the extracellular space. These are released by a parent cell, can be taken up by a recipient cell, and they are capable of mediating cellular signaling by carrying nucleic acids, proteins, lipids, and cellular metabolites between cells and organs. What's been found is that circulating EVs may be a biomarker for metabolic syndrome. It's still not, it's a very early notion. We've still not pointed, but trends are pointing towards a relationship between the quantities of blood-based EVs and metabolic syndrome. Another one is freely circulating microRNAs. Now, microRNAs are non-coding RNAs, but which have important roles in regulating gene expression. MicroRNAs and those microRNAs which are carried in the extracellular vesicles that we mentioned earlier are also under investigation for as biomarkers for metabolic syndrome. Because this interest is high, because they appear to be causally and mechanistically involved in events that contribute to metabolic syndrome. Now, all of this can be boiled down to just one chart of all these parameters that I've talked about. ApoB1A1 ratio, LPA, uric acid, GGT, OXLDL, HSCRP, cystatin C, LP, PLA2, IL6, TNF alpha, leptin, and platelet HDL-C ratio. All of them are increased in metabolic syndrome, and adiponectin and ghrelin are decreased in metabolic syndrome. Similarly, leptin-adiponectin ratio will also be increased in metabolic syndrome. Hopefully, I have been able to give you a quick look at the peek at the next 10 years and how that looks like. Thank you. I would like to thank the organizers of this CME for such a wonderful job and making us all feel welcome having such sessions. Thank you.
Dr. Vineet, I am so glad that you could make it for today's CME. because when Anupa and me were discussing what all to have and what all to include, metabolic syndrome is something I was insisting. I said, I will not have a CME without the metabolic syndrome being discussed, because I feel metabolic syndromes affects each and every pathy. It affects
Yes.
each and every specialty, and it affects the spectrum of all diseases. All right. So it was very, very important for us to diagnose that the patient is, entering into a metabolic syndrome or something like that, which will guide us in the therapy. So thank you very, very much.
Thank you. You're so kind. And frankly, I agree completely with what you said. The prevalence of metabolic syndrome is going up so high now, given the lifestyle changes that people are having, the lack of activity, the increased weight. It's something it's a big public emergency, in fact. And there's a lot of research going into it. And this is just a small glimpse into it. There are beautiful articles out there on so many other new markers that are coming. And by the way, all the markers that I've discussed today are currently available in India. These are not, something out of the future.
I think that is one of the most important things that you did today, Dr. Vineet, because many a time we hear of a lot of investigations that are there, but India mein nahi hota, hamare yahan nahi hota. So what is the point of discussing?
No,
this is a very important aspect.
There are pentraxin 3, paraoxonase and all, they are available in the West. But not in India, unfortunately. That's why I was like, okay, there's no point in me talking about it. So better to stick to those parameters which are there. You can get all these tests. But currently, there are no guidelines for reference ranges in India. And there are no organizations which are specifically saying that, okay, you can use this as a cutoff. But physicians, your clinical acumen comes first before anything else. You can definitely use your own clinical acumen, your own knowledge to use these to bolster whatever diagnosis and monitoring that you're doing for your patients.
Let us today inspire people like you to take this forward for India. We have a huge population. You will have a huge database. And I guess Suburban could take the lead in working out some kind of standards for the Indian population. Anupa, are you listening?
Yes, very much. Noted.
Good girl.
Yeah, it has to be noted. It's noted. We have to make a change here.
Yes.
We have to make a change.
Yeah, thank you so much, sir, for
Thank
such a
you.
wonderful take-home messages, I must say, and real practical tests which can be applied in Indian scenario. Thank you so much, sir.
You're welcome. Thank you so much. Thank you again to the organizers, Dr. Nilima, Dr. Hemant, Dr. Ashwini. Thank you so much.
Thank you, Dr.
Thank you. Let's move ahead with the next talk, which is Dr. Saurabh Dani, sir. He will be talking on newborn screening. So Dr. Saurabh Dani, we all know him, consultant OBGY, Ankur Namaha, Cloud9 Hospital. He is attached. Special interest is high-risk pregnancy and newborn screening. And also, he's a vice president of Indian Society of Prenatal Diagnosis and Therapy. He's treasurer at Bombay Nursing Home Association, past president of Association of Fellow Gynecologists Mumbai, scientific secretary Kandivali Medical Association, and coordinator of MCGM Newborn Screening Program 2019-22. Welcome, sir. Over to you. It is a pre-recorded talk, I guess.
Somewhere in the interior, he's been able to join. It is really proud to know you, Saurabh, and Saurabh is doing a fabulous job where getting the newborn screening onto the government panel is concerned. So my congratulations to you, Saurabh, and it has been a great pleasure to know you professionally and personally also as a friend. Thank you.
Good morning, everybody. I would like to thank AMC for inviting me to give this talk on newborn screening, and would personally like to thank Dr. Nilima Vambare and Dr. Dugar for their efforts towards doing this program and inviting me to give and throw some light on a topic which is a little unconventional. So the whole session today is dedicated towards recent diagnosis or latest things which are happening in the field of diagnostics. But unfortunately, what I'm going to talk about is nothing new or is nothing recent. To give a little history or the context to what I'm trying to say, let me share a little history. So the topic which I'm going to talk is newborn screening. And the history is that newborn screening started way back somewhere in 1960. So Dr. Robert Guthrie is credited with the development of a very simple test to screen for PKU. And in 1970, then the first test for TSH was developed. And in 1990, a tandem mass spectro test was developed, which basically took care of multiple disorders using a single spot of blood. So if we are really talking about recent, then there is nothing recent about it. It's almost 32 years ago when the whole thing was invented. And there are several countries across the world where this is being implemented as a public healthcare program. Now, coming back to India, this definitely is recent in some sense because we don't see a lot of public health programs happening in the space of newborn screening, and a few percentage of babies are only being screened as far as the newborn screening is concerned. So the way I would put it is newborn screening is not a test, but it's a program. So we have to treat it like any other program which is currently being supported by the government and the public healthcare authorities, like the polio eradication program, the national TB eradication program, the pulse polio program, and things like that. Now, why do I say it's a program? Purely because the babies who are visiting your clinic. It could be all the babies who are born in a certain geographical area like Mumbai or Maharashtra or India, like that. So then the next step comes. So whom do we offer this test? So the pre-screening to the appropriate individuals. So the appropriate individuals in this case is going to be all the newborns which are born. Okay, so any live baby which is born is basically the appropriate individual. Then the process is defined, that is when the test is done, how the test is done, where is the sample going to be sent for reporting, how will the reporting happen. Okay, so that is going to be your process. Then the post screening. So once the report is generated, if it is normal, what is to be done, and if it is abnormal, what is to be done. And here, because it's a screening test, the focus is going to be on all the abnormal results. So whenever it's an abnormal, we need to do a confirmatory test for the same. And once a confirmatory test is done, and that also turns out to be a similar result to the screening test, then the last step starts, that is the follow-up, diagnosis, and treatment of the same. So this is how we really take care and define it as a program. So I have been associated with the MCGM newborn screening program from 2019 to 2022. And the highlights of the program were that it was a target-based population. So what was the target was all the babies who are born in the 4 medical colleges, that is SAN, NAT, AIM, and Cooper, were being screened. So what do we screen for them for? Thyroid, congenital adrenal hyperplasia, G6PD, and hemoglobinopathies. Now these 4 disorders were chosen because they are part of the guidelines and also part of the Wilson-Jagnes criteria. So I'm sure if you need to know more, you can always Google up and find out what the RUS guidelines and the Wilson-Jagnes criteria are. So what was the process? The process was that a baby's heel is pricked after 24 hours of birth. Then the sample is collected on a special filter paper, and hence it is allowed to dry. That is why it is called as a dry blood spot. And then the tests were done on the same. That is TSH was done for congenital hypothyroidism. 17-OHP was done for CAH. A G6PD semi-quantitative test is done for G6PD. And a HPLC test is done for the various hemoglobinopathies, specifically focusing on thalassemia major and sickle cell disease. The results would be available to the institute in 96 hours, and then it would be followed by a post-test counseling in case the results turn out to be presumptive positive. If they turn out to be presumptive positive, then the babies are recalled for a confirmatory test. And if the confirmatory test also proves the same, then the clinical management is initiated. So the first sample was collected on 13 September 2019. So this is the data between 2019 to 2021. I'm sure the number of babies are less purely because the program was disrupted due to the COVID pandemic. So for a couple of months, the screening program had been suspended. In total, the screening program in that period, we screened for almost 26,000 babies. And the incidence of thyroid was almost 1 in 2,000. CAH is 1 in 6,500. G6PD is 1 in 200. And the hemoglobinopathies is 1 in 74. So if we look at the overall incidence, it's almost 1 in 50. So that's a pretty high incidence of the disorders that we were trying to screen for. Now, if you look at the real population which was being covered in the newborn screening program and what was not covered, you will realize that what we were doing is just the tip of the iceberg. So, if you all understand the Indian healthcare scenario, how it is really? It is some hospitals are managed or the healthcare is by the central government, then the state government, and then there are private players. So, if you look at central, then we have institutes like All India Institutes where this babies are not being screened. So this program was not covering this part. In Bombay, we don't have any aims. In the state, we have Director of Health Services, which manages all the PHCs and everything. Then the Director of Medical Education, which basically manages government medical colleges, so like JJ Hospital. And then we have the Municipal Corporation, under which we have the Sion, Nair, KEM, Cooper, and several other hospitals and peripheral birthing centers. So if you really look, what we were covering is a small population of all the births which were happening in Mumbai. What was also not included were the nursing homes, charitable hospitals, and corporate hospitals, which obviously they would have to do it on their own means. So this is the data from the last 3 years. And if you really look at the data, what important part you need to realize is that if you look at the number of births which are happening in the jurisdiction of Mumbai, then there is almost a 50-50% between the public healthcare facilities and the private facilities. So if the private facilities don't start including newborn screening, then we are not missing out on screening almost 50% of the babies. So the need of the hour is that we need to screen more and more babies, because only when you screen babies, you are going to be able to detect them, and then you are going to be able to offer them a treatment which will help in reducing the infant mortality and morbidity. The public healthcare program, which was currently only for the 4 medical colleges, also needs to be expanded to include more babies and all the other peripheral hospitals under the municipal corporation jurisdiction. And the private hospitals need to implement it in their own setup, in their own way. And most importantly, this is not something which an obstetrician society or a neonatologist alone can do it. And both the people need to work together to come and advocate this program. Only then we will see a successful program in the future. So basically, if you really look at what a basic newborn screening program should be, it should be universal in nature. That means all the babies who are in that facility have to be screened, and they should be screened for thyroid, they should be screened for CH, they should be screened for G6PD, thalassemia and sickle cell disorders, and congenital hearing deafness. So that should be a part of the universal screening panel. So just to give you a little idea, I'm going to talk this in terms of cases rather than giving a talk which is going to be purely a one-way kind of a thing. So let's look at a simple case. Now I'm going to present it from the 2 point of views. One is the obstetrician point of view. So this is Mrs. Aarti, who was a primary gravida, was admitted in a private nursing home in suburban Mumbai. She had a history of preeclampsia, diabetes, anemia, hypothyroidism, and was on treatment for all of them. On 4th November, when she got admitted, her hemoglobin was 8 gram%, and her sugars were controlled on insulin at 73 grams. The TSH was at 5.7 on treatment, LDH was 119. So she delivered a healthy baby on 2nd of November by elective C-section. Then because her hemoglobin was low, she was given iron therapy. And then since everything was fine, the baby and mother both were discharged on 5th of November. So if you really look from an obstetrician point of view, I think everything was done perfectly well. Now I know that with several legal luminaries we are always going to see that there is going to be something which is left out. But then the whole idea is not that, but to just create awareness on how things unfolded. Now I'm sure this baby is very lucky. Now why? Because this baby happened to visit a pediatrician who was very much inclined with performing universal newborn screening. So when the baby was visiting the pediatrician asked that, have you done a newborn screening test where you have delivered? Obviously the parents said no, that was not done. So they said, okay, fine, get it done. And the parents told us that contacted us and told us that we need to get a newborn screening test done, which was done. So we were contacted on 9th. By 10th, the sample was collected. The sample reached the lab on 11th, and the report was issued on 12th. And the report was the TSH levels were 34. Now, when I say 34 on dry blood spot, that practically means 70 when you're doing a plasma blood TSH level. So it's almost double. So with a level of 34, everybody became highly alert. And what we told them is that, okay, we need to do further testing and confirm if this is really true. So going to really the causes of hypothyroidism, if you really try to understand, the most common causes of hypothyroidism is not because of some hereditary factor or something, or because of the mother's thyroid status, but purely because of the dysgenesis or the non-formation of the thyroid gland. So this accounts to almost 85% of the cases. Then there is another 10 to 15% of the cases, which is almost the rest of all the cases, is around dedicated towards the cause of the problem is because the hormone, the thyroid hormone which has to be formed is not properly formed. And then we have these rare cases of TSH resistance and central hypothyroidism. So the bulk of the cases are nowhere related to either genetic in nature or because of the thyroid status of the mother. So this is something which is very important that you need to keep in mind. Another important thing to keep in mind is that the TSH levels in the first 24 hours of birth are quite erratic. So this graph will tell you about the TSH levels. It takes 24 hours for them to settle. And hence you never do the TSH in the first 24 hours. Neither you do it from the cord blood or even collect the sample at 12 hours of birth. But you wait for the 24 hours to pass, let the TSH level settle down, and that is when you do it. This is the whole idea, is to take care of the false positives. Otherwise, you'll end up getting a lot of false positives. So again, as I said, the confirmatory test was done. So by 13th November, we got the TSH values, which is 92.0. So immediately the baby was started on levothyroxine. Then a thyroid sonography was done, and it proved that this baby falls in the 85% of the category, that is agenesis of the thyroid gland. Since I also said that the hearing screening is also part of the newborn screening panel, and hearing screening was also done, and it was found that the baby had single-sided hearing deafness. So on the right side, the baby could hear properly, on the left, the baby could not hear. Once the treatment has started, then again the TSH levels were repeated after a certain number of days. By 6th December, because of the treatment, the TSH levels came to normal. So purely because of the early intervention, diagnosis and treatment, this baby is saved from mental retardation. So if a baby is untreated, undiagnosed for about 4 weeks of life, then the IQ starts falling by around 5 points every week. Okay, so that's really very important. And incidentally, this is the kind of data which is available in public literature, is that there is a prevalence of hearing impairment in cases of primary congenital hypothyroidism. So there is almost a 33% chances of the child having kind of a deafness in case of congenital hypothyroidism. So let me talk about another case. So this is going to be a case 2. So again, this is going to be this is a primary gravida who is delivered in a public hospital for post-dated. The baby weight was 3 kilos and 570 grams. The baby was born on 29th of December 2020. There was absolutely no significant antenatal history or a family history or a medical history. So because the baby was born on 29th, the 30th, the newborn screening test was done. And by first, we got a report showing hemoglobin F pattern. Now, when it says hemoglobin F means what are we expecting in the hemoglobin at that time is the adult hemoglobin as well as the fetal hemoglobin. But then adult hemoglobin was not found at all. So this is how a report is given, report F only. So this means that this child is probably having a beta thal major. Now, the only way the beta thal major is possible is both the parents are having thal minor. Now, there was no history, there was no clinical symptoms that warranted a screening test to be done on the parents. And probably that was the reason why this was missed out. So this is the report, a genetic report done at NIH in KEM, and both the parents' reports were done and confirmed that both of them are thal minor traits. And this is the report of the baby, which confirms that it is a homozygous for beta thalassemia. So it's basically a thalassemia major child. So again here, it's very easy to really detect all these problems if you are really aware that a newborn screening should be done after 24 hours of birth. And once it is done, then all the diagnosis, treatment, everything will follow. But the first step is going to be, yes, initiating a program. So this is going to be my third case, wherein we have Mrs. Savitri. She's a second para. She again delivered in a public hospital. She was 40, she was due. Baby weight was 2.6 and date of birth was 21st of March 2020. Again, no significant antenatal or medical or family history. The baby had no history during the, or no clinical problems during the stay at birth in the hospital. Again, as routine, because it was, the program was going on in the municipal hospital. On 23rd March, the newborn screening test was done, and by 25th, we got the report saying that the G6PD enzyme activity was 1.48. Now, normal activity is above 2. So, this was definitely deficient. So, that means we were suspecting a G6PD deficient baby. Now, the next step is that we need to confirm. So, within a couple of days, the baby was recalled and a confirmatory done on the whole blood, and which also confirmed our diagnosis is that G6PD values are 55, which is way low than what we would expect is around 146. So this confirms that a G6PD test is done. Now, fortunately, this child didn't have any symptoms. It didn't have jaundice, didn't have anything. But this also leads us to the fact that we would not expect jaundice to be happening in each and every cases of G6PD deficiency. And some of them you would miss out. And if you miss out, and these babies end up receiving some drugs or food or something which is contraindicated in G6PD deficient babies, then it would cause a hemolytic crisis, which is the whole idea of avoiding and trying to find out as early as possible. So what we do with this child is, now this child and the parents are called, they are given a list of things that they need to avoid giving the baby, and a card is issued to them saying that if you visit any doctor anywhere in any part of the world, all you need to tell them is that my child is G6PD deficient, and accordingly then the doctors would see to it that they don't give medicines which are contraindicated in a G6PD deficient child. So when I say that newborn screening is a must, so what are we really talking about? In antenatal period, we are doing a lot of screening tests. If you look, we do screening tests for Down syndrome, wherein the incidence is somewhere around 1 in 800. We do a VDRL test for syphilis. The incidence is almost 1 in 1,000. We did a beta thalassemia screening test, HPLC, for the mother. That incidence is almost 1 in 800. On the other hand, what we don't do till date is the MCGM panel or the universal newborn screening panel, where incidence is much higher than the things which are already even doing today. And the incidence put is 1 in 50. So just looking at the incidence and data, it is definitely warranted that newborn screening or a basic newborn screening should be part and parcel of a providing healthcare facility in any place and every setup wherever the babies are being born. So again, to reinstate the fact or the data, see, thyroid is G6PD, CAH, and hemoglobinopathies. This is the 4 things that you need to do, which are going to be the blood-based test, and then you have to add a hearing test, which is also going to be done in-house. So finally, before I end my presentation, what I would like to say is that this is, the baby is going to fall into the valley of morbidity and mortality, and the only 2 people who can save this baby is the obstetrician and the pediatrician. Not one of them, but both together. So only when they work both in tandem in the interest of the baby, that the baby is going to be saved. So I thank you very much for allowing me to share my views on newborn screening, and I hope I have thrown some light, and hope to see that more and more hospitals, healthcare providers, pregnancy caregivers, child care providers, all of them initiate some form of newborn screening in their own practices. You don't need to wait for the government to initiate a program. This is something very easily possible. Lots and lots of facility, especially in cities like Mumbai or the Mumbai metropolitan region, it's easily available. So we need to start doing it. And I don't need to remind you about the kind of environment that we are, wherein there are so many medical legal issues which are being taken up. by parents, and it should not happen that some parent may just come back to you asking that you should have told us to get it done and we would have done it. So hence, it's very important to document that you have advised a newborn screening test and the patient who has not done it has refused to do a newborn screening test. So that's messaging from my side. I hope you have understood. If you need to get in touch with me, you can always directly email me or call me, and I'm always call away. Thank you very much,
Saurabh,
and
I would like to
have a good day.
lag when you're talking. Could you just correct that?
Network issue, I suppose.
Network issue.
Yeah. So I think we can just unmute her or do that. Just can't hear.
Great work in newborn screening.
Great.
Shared about the Heal to Heal program. Good step forwards. And really, I think that this is something which is preventable. This was a very, very important topic. And I hope a lot of people are going to use it.
Yeah,
Ashwini,
absolutely
I think you
fantastic.
take over.
Yes, madam. It was a fantastic talk, and I guess it's a perfect teamwork he has explained between the gynecologist and the pediatrician. Both should be working together to avoid further medical legal issues also. Let's move ahead with our last talk of this program. Dr. Ashish Joshi. He will be talking on innovations in cancer diagnostics. Sir is consultant medical oncologist, director, and co-founder of Mumbai Onco Care. Over to you, sir.
Hi, good afternoon, everyone. Am I audible?
Yes, sir.
Yes,
Very
sir.
much.
Yeah, I'll just share my screen.
We are going to have a full-fledged CME on all about cancer next week. And Dr. Ashish is going to take care of the entire CME that day. Today, he's going to just throw light on the diagnostics part because today's theme was diagnostics.
Yeah. So thank you so much, organizers. Thank you, Dr. Nilima. Thank you, Dr. Hemant, for giving me this opportunity. Well, I think whatever has changed in oncology in last decade or so has entirely to do with increased understanding in cancer biology and reflecting it into what is obviously translating into innovations in cancer diagnostics. When I started my practice around 12 years back, what I was practicing was diagnostic test, which I was doing is quite disparate than what I do in 2022, 2023. And hence, these are the buzzwords as we speak: molecular oncology, FISH, PCR, NGS, and the scientific media in terms of oncology ecosystem is full of these words, which will keep on resonating in the landscape of modern oncology as we speak. So at the risk of being too simplistic, one may easily say that today, if you are a medical oncologist, you have to be a molecular oncologist. Today, if you are a medical oncologist, you must understand what are the innovations in cancer diagnostics. You must understand what is FISH. You must understand what is PCR. You must understand what is NGS. And if you are not a molecular oncologist, you are not a medical oncologist. And I think at the risk of being too simplistic, again, I reiterate here that these are very, very important concepts that has come a long way in making a change in the cancer treatment. And lot has to do with the innovations in cancer diagnostics. Paradigm shift in the diagnostic approach, I think all of us know. It's all started with the basic histology, which is again very, very important. We obviously cannot shift the rows. It has to go from sequence. So good histopathology is extremely important. To elucidate more about oncology and the pathology and the biology of the disease, we typically nowadays reflexively do what is called as immunohistochemistry. And I think all of us know that without a good immunohistochemistry, diagnosis of malignancy is difficult. But nowadays, we are moving it further that only immunohistochemistry is not important. This shift from immunohistochemistry to the molecular oncology is what the innovations that we speak about, and that is what going to be the focus of my discussion. Histological subtyping of tumor has been in vogue since long. We started with the basic microscopy. We have moved to microarray. Now we are talking about molecules and mutations. And that's what the buzzword, that's what is molecular oncology all about. What I'm going to talk in next few minutes or so is something which is not utopian, something which is very, very routinely practiced in day-to-day oncology, something which all of us practice on Monday morning, something which is very much available to all the patients that we cater to, something which is available in India very, very much thanks to the great diagnostic facilities that we have with us. So the 21st century approach is refined choices at the molecular level, and this is what we are looking at. Initially, all the medical oncologists were like this. They had a cytotoxic cocktails, and it was a blind game. You try to disseminate everything, you try to disseminate good, but you try to disseminate ugly, and then that's where the cytotoxic side effects of the chemotherapy, which was talked about. But because of the innovation in the diagnostics, it's a medical oncologist dream has come true. It's an individualized treatment approach. It is a provision of a personalized cancer medicine. It's the provision of the understanding of the disease biology of an individual patient is what resonates the landscape of medical oncology as we speak today. So the proof of the pudding is, of course, it's an example. And it's not something that we did not know molecular oncology. And this goes way back in probably 1980s. And this is the case which was there. And let's start with a simple case to give you an insight or to give you a proof as to how it works. Let's say there are two patients, patient 1 and patient 2, both around 60-year-old male, both present to a physician with increased fatigue and weight loss. There is a moderate splenomegaly, there is no hepatomegaly, there is no lymphadenopathy, hemoglobin of anemia for both, total WBC count of 1,20,000, platelet counts around 2 lakhs for both. The peripheral smear shows basophilia, and this is the classic peripheral smear which is seen in both patient 1 and patient 2. Now it could be anybody's guess, and I think this is very simplistic, that this peripheral smear is characteristic of a chronic myeloid leukemia. You can see an exuberant myeloid proliferation which is seen, which is characteristic of what we call as CML. But the story doesn't end here. Let's look at what happens to patient 1 and patient 2 when the patient walks into the clinic. Of course, the physician will discuss with the patient that additional tests will be needed for a correct diagnosis. If test, which test? And for the patient 2 as well, it will be discussed that there will be something more which will be required. And if test, which test? And the test, of course, a vagrant observation which we had is something called as Philadelphia chromosome. I think all of us know that. So patient X had all the trappings of a chronic myeloid leukemia. He had splenomegaly. He did not have lymphadenopathy. He had leukocytosis. He had basophilia. The peripheral smear of patient X as well as patient Y exactly look the same. But what is the difference? What is the disparate between patient X and patient Y? Is the patient X has a Philadelphia chromosome which is positive. Patient Y has Philadelphia chromosome which is negative. So what changes? You would wonder that everything is the same, the peripheral smear is the same, the age is the same, the phenotypic profiling is the same, but it's the genes which are different. So the patient X has got a Philadelphia chromosome which is positive and hence would be diagnosed to have chronic myeloid leukemia, whereas the patient Y does not have CML. So look at what has changed. So the change is in the diagnosis of the disease, and the diagnosis of the disease is genetic. Somebody who has got splenomegaly, leukocytosis, and a peripheral smear exactly matching of a chronic myeloid leukemia, but does not have Philadelphia chromosome or does not have the genes to have been positive, does not have chronic myeloid leukemia. Whereas the patient who has a Philadelphia chromosome positive and has all the trappings of leukocytosis and splenomegaly actually is the only one who has chronic myeloid leukemia. You would wonder, Dr. Joshi, how does it make a difference? It's just the nomenclature, or it's just the outcome of a patient? So let's have a look at this. From a crude concept, we are going to a fine tuning of the diagnosis. With a gene test, we can differentiate between specific cancer and other malignant conditions or a reactive cause. We can target the abnormalities peculiar to the cancer, and that's how the concepts have changed. So this is the BCR-ABL gene, which has been active in a patients with Philadelphia chromosome. And if the Philadelphia chromosome is positive in a patients with chronic myeloid leukemia, then we could target that with a beautiful drug called as imatinib, and of course, many of them as we speak. And the treatment outcomes dramatically changes. So you look at a situation that up until 1980s, it was chemotherapy and allogenic stem cell transplant, which was resonating the landscape of treatment of chronic myeloid leukemia, because we simply did not know that something Philadelphia chromosome or a gene test exists. But the moment we started understanding the biology of this disease, we started knowing that somebody who has got a Philadelphia chromosome positive, and if you could give a drug called as imatinib, you could dramatically change the outcome of a patient, then you could change the definition of the disease. So innovation in the diagnostics has redefined the disease as we speak in modern oncology. So somebody, let's say in 2022, has got all the trappings of a chronic myeloid leukemia, but does not have the gene test positive, will actually end up receiving chemotherapy, stem cell transplant, interferons, and so on and so forth. But somebody who has all the trappings of CML and also has got a gene test positive and indeed has got a chronic myeloid leukemia will be treated with a single drug called as imatinib. And the outcome of such patients, as we can see here, that the 7-year survival is upwards of 86%. And if the modern medicines are used, which are ahead of imatinib, then you could take it up to 95% to the extent that we are looking at operational cure of a disease. So look at the change in the therapeutics in the patient outcome, just because greater insight into the understanding of the disease, greater insight into the diagnostic approaches. And now we have a simple test for Philadelphia chromosome, which is redefining, reshaping the way this patient would behave. So it's all about genes. And that's what the innovations in diagnostic is all about. We are talking about the molecular test. We are going to talk the clinical utility of this test. And we are going to just briefly discuss how this enables me as an oncologist and we as a caregivers in precising the treatment options for cancer patients. So cancer is a disease of the genome. Genes resonates the picture of oncology, and it's our ability to identify these genetic abnormalities. Mind you, genes does not necessarily means hereditary cancers. The genes also means somatic cancers. So many of this, almost 95% of our patients would not be having a hereditary cancer syndrome. But it's the gene which is creating the games. It's the genes, and it's our ability to find out the genes which is the core concept in the innovations in diagnosing as far as the oncology is concerned. So how do we do that? So only subset of genes are relevant in cancers. And you know that human genome is constituted by 22,000 genes. And it's only on those 1.5% of the gene which are relevant in an individual cancer. And how does these genomic alterations cause cancer? We obviously know that DNMX, RNMX proteins is the classic teaching that we all have been taught in the basic biochemistry. Altered DNA causes altered RNA causes altered protein expression, and altered protein expression causes altered pathways. And it's our ability to capture these events in the oncogenesis, which is very, very important as far as the diagnostics innovations is concerned. And we have been able to capture these genetic variations with various tests that are available, and I will allude to that in few of my next slides. But what entirely happens at the end of the day is the uncontrolled proliferation and uncontrolled survival, which is the characteristic of any oncogenesis for any solid tumors, be it a solid tumor, be it a hematolymphoid malignancy. And targeting these specific signaling pathways, it's a cancer genome is a very depressing page. It's all about linkages. It's all about networking, and the cancer cells are networking it exuberantly. And if we can target this specific signaling pathway by identifying them, then probably you're going to achieve the cancer control which is deeper, cancer control which is more punchy, and cancer control which is probably devoid of a lot of side effects of a cytotoxic drugs. So there are plethora of treatment options available at our disposal because of our ability to understand more about the cancer biology, because of the innovations in the cancer diagnostics. So to be specific, there are EGFR inhibitors. To be specific, there are immune checkpoint inhibitors. To be specific, there are telomerase inhibitors. And mind you, these are all the events which are happening in many cancers. And it's our ability to capture an event in an individual cancer which resonates and will guide us in the treatment decision as far as the modern molecular oncology is concerned. So revolution in cancer care has come at the expense of the innovations which have happened in cancer diagnostics. We had one drug fits all, typically a cytotoxic drug which is going to kill everything. Then probably we understood that there is a biomarker, there is possibly a diagnostic tool which will help us to find out a particular drug for a particular patient. And then eventually we ended up probably understanding more about individual drug, individual patient, and individual genes in an individual patient. So probably we have got four or five or more than 10 options for an individual patients down as we speak. So cancer care is becoming more personalized, moving towards an individualized treatment plan, as has been seen here. So advances in cancer biology is driving a future where cancer care is becoming fully personalized. Just again, a proof of pudding, something which we will feel is not a drudgery or not very, very depressing molecular oncology, something which is happening day to day. Now, number of targeted therapies are rising as we speak. And as mentioned before, I reiterate here something which I started in my clinical practice early 10 years back. I probably had only 3 molecules in treating lung cancer. Probably as I speak today, I got close to 15 plus molecules to treat my cancer patients, and the outcomes have dramatically changed because we have been able to understand the targets, and probably we could target them in an individual patient. Then we could probably achieve a utopian goal of cancer control/cure. So that is how the things go about. So lung cancer is the lead indication. Lung cancer treatment few years back was a very depressing situation. It was basically a best supportive care, tell the patient to go home, probably give few rounds of cytotoxic chemotherapy, and that's it. But now as we speak, lung cancer is a disease of mutations. And these are all the mutations which are activated in some sort of lung cancers. And it's our ability to find out these mutations, these amplifications, these rearrangements, and there is a drug, mind you, at every mutation level, we could probably make the change in the outcome of these lung cancer patients. Clinical practice is evolving with the understanding of the cancer biology, where treatment decisions are based on cancer's molecular alteration. Now, what are these genomic alterations that are driving the tumor growth? It's just one base, maybe just change T to G, and then you have got a mutation. This is typically what is seen in EGFR mutation, which is so commonly seen in lung cancer. So it's genomic alteration, which is called as base substitution. That is one of the ways in which cancer gets mutated, the cancer cells gets mutated. Then there is a copy number alteration. The number of genes which are amplified can also vary. For example, a very simplistic example, I think all of us know that HER2/neu amplification. Now, HER2/neu amplification is so commonly seen in breast cancer, and as we would speak, it would also be seen in many other cancers. And we have a beautiful drug called as Herceptin, which could possibly target this. And the ability of Herceptin to control the disease is so mammoth that we have been able to change the course of these patients, which are HER2/neu amplified breast cancer and so many other solid tumors, dramatically. Genomic alterations could also be rearrangements, as has been seen in Philadelphia chromosome, where there is a fusion of T822 and RET fusion, TMPRS, ERG fusion in prostate cancer, and so on and so forth. So gene alteration, copy number alteration, and gene fusions are very important events which are governing or defining the cancer growth. And how do we capture them? And do we capture them with the innovations in cancer diagnostics? So as I mentioned to you before, it's the flow of event which starts from a classic histopathology. Then we move on to immunohistochemistry, which probably can identify the personality of the tumor better. But as we deep dive into the understanding of the cancer genome, we understand it by doing a test called as FISH, which is a fluorescent in situ hybridization, a PCR, which is polymerase chain reaction, and Sanger's based sequencing, and now what we typically call as NGS based hotspot testing and a comprehensive genomic profile. So these three new words, I would request that probably the technicalities we could probably ignore, but the concept is that we are diving more into the molecular level, going into the deep of the cancer genome to understand more about the personality of the cancer. So the Sanger sequencing, NGS-based hotspot testing, and the comprehensive genomic profile and the whole genome sequencing is the sequence in which we have moved very rapidly in last couple of a decade or so in understanding the disease biology, in understanding the innovations, and in understanding the targets. So typically the FISH is what is done. It's an in situ hybridization assay and the PCR and the genomic sequencing. And it's our ability to capture all the three events which I had mentioned to you. And all these tests do the same, but it's their specificity and the sensitivity which makes all the difference. And I would just allude to few of those in next couple of my slides. So the category 1 is a classic immunohistochemistry PCR and FISH test, wherein you could identify a one particular gene or a one particular molecular abnormalities in the cancer, but a lot of other things would be missed, which could also be very, very relevant. Then come the multi-gene hotspot test, wherein you have a little broader scope of understanding, but still much narrower compared to what the subsequent test will do. So the hotspot NGS is something which is very commonly used, which can identify the gene of interest, but for that you need to understand the gene in an individual patient. But something which is more important is the comprehensive genomic profiling, and that's the buzzword which I had mentioned to you about, next generation sequencing. So what it basically does is that we have to send the tumor blocks or the tissue blocks from the histopathology specimen, and it studies maybe 150, 200 cancer forming genes in an individual patient in that individual block. And it's our ability to find out this 3 genetic alteration in either of those 150 genes in an individual patient that probably give us the exact understanding as to why a cancer has been seen in this individual A or B or C, and do we have a drug to control the disease in individual A, B, and C. So that's what the comprehensive genomic profiling does. There are various types of NGS, and I would not like to go too much into the technicalities, but the concept again is try to elucidate the encyclopedia of a cancer in an individual patient, try to elucidate which particular amongst those 300 cancer forming genes which have been altered in an individual patient, and try to capture those and try to find out what is happening in an individual patient, and can we target those. For example, 17% of EGFR exon 19 deletions can be picked up by hotspots. 22% of EGFR point mutations can be missed by the standard test. 15% of HER2 mutations can be missed by IHC, which can be picked up on FSA by FISH. 26% of lung cancer NCCN genes versus hotspots can be missed by the hotspot, could be picked up by comprehensive genomic analysis, and so on and so forth. The point to note that these numbers, 17%, 22%, 15%, are quite punchy when we look at an individual patient, because probably if you go deep dive into more sophisticated tests like a comprehensive genomic analysis, maybe 35 to 40% of the test of the genes which are probably going to be active are missed if you rely only on the basic immunohistochemistry or the basic histopathology or a basic FISH test. So it's very important, it's very pertinent then that we have innovation in diagnostics which could help us in elucidate more about the disease biology of the cancer. So as I had mentioned to you, genomic sequencing, exome sequencing, and targeted panels are various ways in which the NGS does. But critically, for our viewers here, simplistically put it, that it's the 3 genomic alteration which are captured, and the methods could be very variable. And as we speak of NGS, it's more comprehensive, more robust, more specific, and more sensitive in picking up the process. The CGP process, a very basic purview, that how do we do that? It's a basic pathology. You cannot bypass the basic histopathology. The laboratory prepares a tumor block, and it's the computational pipeline and the information review or the AI-based tools which are used to content and create the genome of an individual patient, and the typical report comes with a whole understanding of a genome in an individual patient, and also the recommendation for a targeted therapies. Something akin to what we do as far as the antibiotic sensitivity in a culture test, wherein you do get a MIC value and you do get the antibiotic which probably would be sensitive. It's something akin to that, but something not as similar, as simplistic as what a culture sensitivity would do. So we have moved from a conventional pathology, which is of course very, very important, down to a molecular oncology, moving from histopathology to immunohistochemistry to FISH and the PCR, which are simplistic assays to pick up a gene, then a hotspot test to pick up maybe 10 genes, and then a comprehensive genomic analysis to pick up 150 genes. And why do we need to do that? Because we probably have targets to identify, pick up, and hit those genes to achieve better disease control. So this is typically the overview of how a foundation medicine or a comprehensive genomic workflow does. From the lab, the DNA is extracted, then there is a sequencing, and then you find out the base substitution, alteration, copy number alteration, or gene fusions, and then you typically get the clinical report. So pathology to mutation-driven cancers is the buzzword. Let us look at multiple stage 4 cancers. And this is just few of my last slides, because this has got a lot of practical implications. Look at colon. This is the Pandora's box. There are multiple cancer patients lying out in this box. Colon cancer, lung cancer, gallbladder cancer, pancreatic cancers, all of them have got adenocarcinomas. But look at how differently they would be treated today. They may be having same stage 4 disease. They may be having same adenocarcinoma histology. But what I am interested in as an oncologist is what is the genetic alteration. So you could be having in the same box 69-year-old male with a colon cancer which has got a DMMR mutation. You could have a 53-year-old male with a gallbladder cancer which is HER2/neu overexpressed. You could have a pancreatic cancer which has got PDL1 overexpression. You got melanoma which is BRAF mutated, which you have got female HRD positive ovarian cancer. And mind you, all these cancer would be treated very, very differently, though the common theme in all of them is the advanced stage adenocarcinoma histology. And that is the landscape which resonates as far as the modern molecular oncology is concerned. Let's look at the HER2/neu expression. Now, HER2, as you know, is overexpressed typically in breast cancer. But what we have also found out that it is overexpressed not only in breast cancer, it's also overexpressed in stomach cancers, gallbladder cancers, lung cancers, metastatic colon cancer, and endometrial cancers. And now actually we test for HER2/neu not only in breast cancer, but all these solid tumors. All these solid tumors, we have adenocarcinoma histology. But if you could find out the common theme which resonates, the landscape of all these various patients which have got a very, very disparate phenotype, is only one gene which is resonating, which is HER2/neu. And if you could find out this HER2/neu positivity in all these various subsets of cancers, then you are actually going to improve the outcome of a patient. Somebody who has got HER2/neu positive stage 4 stomach cancer, he would going to survive with 6 months with chemotherapy alone. But if you have HER2 and if you have anti-HER2 therapy, then the survival is going to catapult from 6 months to 20 months, from 16 months to 40 months, from 5 months to 16 months, from 6 months to 18 months, from 16 months to 36 months. And that's the yawning difference that we have been able to achieve. But it's not the adenocarcinoma which is governing it. It's the HER2/neu protein. It's the gene which is governing the oncogenesis of events in all these patients. So in fact, nowadays what we are talking is not about whether it's adenocarcinoma or it's a squamous cell carcinoma. It may be a HER2/neu positive lung cancer, or it may be a HER2/neu positive colon cancer. The treatment will be similar because we have got anti-HER2/neu treatment for subset of patients which are having HER2/neu expression. So the diagnosis of the disease has changed from the histopathology to a molecularly driven cancers, and eventually it may not be an overstatement to say that couple of years down the line, or maybe 5 years down the line, you would be talking about HER2/neu positive driven cancers rather than adenocarcinoma, rather than breast cancer, rather than colon cancer. And that's how the disease have changed. So innovation in cancer diagnostic is truly and surely had made a lot of difference. And modern oncology or a molecular oncology is all about understanding the tumor personality with an improved diagnostic in an individual patients. We are moving from a radical therapies to a cancer specific or a personalized cancer care. Mutation studies have enhanced our understanding of the disease. Treating difficult cancers is rewarding with current treatment options. The disease that was impossible to beat few years before. It's not about new medicine alone. It's about the concept and the innovations in diagnostic, which will probably govern the way we would treat modern oncology now onwards. With this, I conclude my talk and would be happy to take any questions if there are any. Thank you so much.
Dr. Ashish, thank you so much. I was little bit skeptical कि अरे कुछ अगले हफ्ते के लिए रखने वाले हो कि नहीं रखने वाले हो, but I'm very, very sure that we have each and every webinar this year that we have planned, we have gone into the depth of what value addition we can give our members. So even when we were doing this pathology thing, every speaker knew exactly what they were going to contribute to the program. And I can see that our webinars being very, very highly appreciated by all. And a lot of effort has actually gone into it. Even next weekend CME that we have on cancers is very, very specific about prevention, about palliative care, about home therapies, and it is not just technical. So I'm very sure that is also going to be a very informative and a very interesting CME. We look forward to seeing MOC in action next week. And again, a very big thank you to Suburban and MOC that they came together, because this CME was dedicated for Suburban, but they were very gracious in allowing the MOC people to enter, because I thought that a specialist who practices every day in cancer was the best person to talk about this. So thank you. United we stand. We give you one more example of this, that all of us, if we stand together, we can take this forward very well. I'm a great and ardent admirer of preventive medicine. I feel that prevention is better than cure. लेकिन अगर disease हो ही जाएगा, so how to deal with it is extremely important. One more take home from this is the Chikati, someone like Dr. Nikhil Datar was able to take the MTP Act to its conclusion, and today we have a much better version. At the same time, Dr. Saurabh Dani did not give up his quest for the newborn screening, and today it is coming onto the MCGM panel. We request all our members who have found something during their practice that this needs to be dealt with. I think you all should come forward. Let AMC know about it if you want our help. And everybody, you want to create clinical data, we are there to help you, because all the specialties are our members. We could circulate Google Forms and try and create this kind of data, because without data, we can't work. Saurabh was able to create that awareness only when he had the data in his hand, because 1 in 50 is the kind of diagnosis we are doing just by screening of newborns. A healthier population, less mental retardation, I think is improving the quality of the citizens of this country, and we will be able to contribute in a much better way to our day-to-day life and to the country at large. Ashwini, I'm very sorry. I keep butting in, all right, every time, but I'm so passionate about what I do, and I'm really sorry to take this away from you, but I hand it over to you now. And thank you for being the MOC today, Ashwini. I know you're very busy. I know you're a practicing laparoscopist, all right? And I know you've taken out too much of time to dedicate to this. And I'm looking forward to you on the motorbike with me. So do not think of going anywhere. You're going to be with me that day. Thank you.
Yes, madam. Definitely, madam. I'm always there for you. And thank you so much for giving me this wonderful opportunity to work with you and AMC. Absolutely fantastic, CME. We are getting so many compliments and positive feedbacks in the chat box. It's a huge success, I guess. Thank you so much. And I'll hand over the screen and digital dials to Dr. Hemant Dugar. Over to you, sir.
Where am I can't see myself. But anyway, both of you have thanked. But the best part is when I started, I said that, in the era of medical legal, more and more overlay, which is pressing us, or you can say bringing us a lot of tension, and we start with a defensive practice. But now listening to today's panelists, and they proved it beyond doubt that it's not a defensive practice, but it is something which, if each one of us understands the innovations, the newer things which are coming in, at least be aware of it and use it in your day-to-day practice. Somewhere or other, you will be able to give a better life to your patient, be a mother, the child, or or the treatment modalities which are there. So thank you very much, Dr. Anupa, Dr. Vinit, Dr. Saurabh, Dr. Ashish, and of course Dr. Gautam. All these people have enlightened us, and as very rightly said by Ashwini, that so many compliments which we were following it up in chat box. So thank you very much. But friends, all those who joined, please do write in your AMC group that motivates us, and it will motivate the other committee members of AMC to bring in more and more innovative seminars. It will help them work hard, because award and rewards is an integral part of any human psychology, because unless you appreciate, you express your appreciation, and uh, uh, that is what motivates, and that's why the awards and rewards are so very important. So thank you very much, all the panelists. Thank you very much, Ashwini, for conducting it so well. And of course, last but not the least, our president, Dr. Nilima, who's been very, very passionate about, and then sees to it the topics are selected, the speakers are selected, and it becomes that how the 3.5 hours are over, nobody understands. It just, the time flies. So thank you very much.
Thank you. Thank you so
Hoping
much.
to see you all at the AMCON. हमारा AMCON भी इस time एकदम हटके है. So 25 और 26 फरवरी, please do not forget, wait, book yourself for those days for the AMCON. It is again very different from what every day we have. So I'm looking forward to meeting you, all of you in person. That will not be a webinar. I do not want to have it as a hybrid as well. So I want you all there personally. So thank you very much. Thank you, Hemant sir, for saying thank you to me. Well, thank you.
No, always. And just one thing to add to what Nilima was talking about AMCON. Friends, I used a word, value for your membership. AMCON will be value for your money, what you will be paying towards attending AMCON. That is the promise from we office bearers of your organization, Association of Medical Consultants. Thank you. Pranab, you can terminate the meeting.